that AMOGS EO group itself.
Yes, ma'am. So we are live now, ma'am.
Yeah.
Yes.
A very warm welcome to all the esteemed faculty members, respected Kiran sir, Bhaskar Pal sir, Pardeshi sir, Girija ma'am, Ramni Devi madam, Arun More sir, and Varsha Baste ma'am. We welcome you to the 57th episode of the AMOGS Emergency Obstetric Committee webinar. This webinar is the brainchild of none other than Dr. Sneha Bhuyar madam, and today it is in association with Nashik, Malegaon, Dhule, Chalisgaon societies. Saiti, can we have the inauguration slide so that we can then introduce Neha ma'am and she can welcome everyone? Okay. So it is my proud privilege to introduce the convener of and the program director, Dr. Sneha Bhuyar madam. Madam has many awards and accolades to her credit. She is the first national faculty from the Yavatmal Society. She has received the Anandibai Joshi Award by Foxy. She has been the past chairperson. Yes, ma'am.
That should suffice.
Ma'am, I request you to formally welcome everyone on this platform.
Sahiti, you can stop sharing. So a very good evening to one and all. My respect to all the seniors here. My respect in regards to all the seniors, the chief guests and guest of honor for today's program, Dr. Bhaskar Pal and Dr. Bhaskar Pal, who is the president-elect of Foxy, and Dr. Kiran Kurtakoti, president of AMOGS, as chief guest for today's program, and Dr. Rajendra Singh Pardesi, immediate past president of AMOGS, and our dear friend, Dr. Varsha Baste, vice president of Foxy, and Dr. Arun More, who is the dean of Government Medical College, Dhule. I would also like to welcome and thank Dr. Bipin Pandit, the secretary of AMOGS, and Dr. Madhuri Mehendare. Sir will not be able to join because of some medical issues. And Dr. Parag Biniwale, my dear friend, as national coordinator of AMOGS, for giving me this free hand to, work for AMOGS Pan India. So I would also like to welcome the president and head secretaries of all the 4 societies of Maharashtra, Dr. Neha Lad from Nashik, Dr. Gauri, the secretary of Nashik, Dr. Tushar Zamre, president of Malegaon, Dr. Anand Patil, secretary Malegaon, Dr. Narendra Zope, president, and Dr. Sachin Khedkar, secretary of Chalisgaon. We also have 2 senior members from Chalisgaon, Dr. Mukund Karamdikar sir and Dr. Ujjwala Devre. And of course, we have as speakers, Madam Ramani Devi, who will be speaking on management of heart disease in pregnancy, and my dear friend, Dr. Girija Bagh, speaking on management of FGR. We do have 2 seniors from senior obstetricians from Nashik, Dr. Prashant Purandare and Dr. Professor Kiran Pature as the experts, and Dr. Aradhana Bhamre, Vishali Patil, and Sumit Wavar as panelists from all these societies. So I would like to welcome one and all. And last but not the least, my dear friends, Dr. Monica Umbadan, very hardworking person, and Dr. Pratibha Baldava, who has worked very hard to coordinate this program. So with this, I would like to welcome and thank all of you. And may I take this privilege to introduce and invite our today's chief guest for the program, Dr. Bhaskar Pal, who is a dear friend, as I have already said, the Foxy president-elect, a senior consultant from Apollo Multispeciality Hospital, Kolkata, and all of you know him, various accolades to his credit, though he was the chair, past president of IAG as well as chair of AICC RCOG. So without wasting much time, I would request Dr. Bhaskar to guide us and, wish us. Over to you, Dr. Bhaskar. Hello. Yes. Yeah, I think some.
Yes, sir.
Am I
Yes, sir,
audible?
you're audible, sir.
Yes.
Okay. No, I am just walking, and that's why I thought that maybe the. Or do you want to take Kiran first? By that time, I'll have a signal restored.
No problem.
Sneha?
Yes, sure.
Yeah, take Kiran. Just give me 2 minutes.
Sneha, I will join a little later.
Yes, my dear. You are welcome.
Yeah.
Please join at your pace. No problem.
Yes.
Okay. I think I am okay. So, Kiran, I will go before you. At the outset, hello.
Yes,
नीचे ठीक तरह से देख के चल और यहाँ बैठ के बोल.
Now I'm static.
Yeah.
It's at the outset, I would again, thank you very much for having me there. It's always a great pleasure to be in any AMOGS activity. I think AMOGS is a trendsetter. It's a most vibrant state organization, and I think it's a pioneer in state organization. Many states have started making organizations, but we have to see and learn from AMOGS. It's a great pleasure to be among friends. Thank you, Sneha, for inviting me here, and I wish you all the best for your forthcoming elections. It's a pleasure to be among close friends like Kiran and Parag and Dr. Pardesi and also Dr. Arun More sir and Dr. Varsha Baste. And congratulations to Monica and Dr. Pratibha for organizing this. I think Sneha's and Monica's programs are always power-packed and educationally very fulfilling. And today also we have topics like heart disease in pregnancy, FGR, and near-miss case scenarios. Monica, all the best to you for your forthcoming elections as well. Once again, thank you very much for having me here. And I also take this opportunity to welcome all the faculties who are here. Thank you for having me.
Thank you, sir. Thank you for your blessings.
thank you, Dr.
Hello,
Bhaskar.
2 minutes मी बोलू का? We are in the meeting. Both of us, myself, Varsha Baste, and Neha Lad, our president of NOGS. We wish all the best to Dr. Sneha, and Dr. Monica, and all of you. Thank you so much. We are among the meeting. Thank you so much.
Thank
you, ma'am.
Thank you, Varsha. Thank you, Neha. So, thank you, Dr. Bhaskar. That was wonderful. Wonderful. It's always wonderful to have you and your blessings and wishes as well. Thank you for being there. So, I would like to invite Dr. Kiran Kurtakoti, a very dear friend of ours since so long, and of course, the AMOGS president. We are very proud of you, Kiran. Yes, please go ahead with your precious words. Thank you.
Yeah, thank you. Thank you so much. At the outset, a very warm welcome on behalf of AMOGS to everyone, Dr. Bhaskar Pal, and I can see also Dr. Ramani Devi, who are outside Maharashtra. So, most welcome to both of you. And Sneha, heartiest congratulations, because this is the 57th episode that I can hear. And really hats off to your dedication and to the dedication of these two AMOGSians who are helping you out throughout, Monica and Dr. Pratibha. So looking forward to the webinar also, and looking forward to meeting all of you, Monica, Pratibha, and everyone in Solapur Society at the zonal conference in the month of November. So thank you so much. And Sneha, you have really involved all our people, and really look forward to listening to Dr. Arun, as well as to listening to Dr. Ramani Devi and Girija, and of course interacting with them. So thank you so much. My best wishes to you also, because your persistence is really admirable. So thank you, Sneha, for being for conducting these episodes repeatedly for AMOGS. Thank you so much, and my best wishes to the program and to the future. Thank you so much.
Thank you so much. Thank you that
Thank you, sir.
to us. Thank you. May I invite Dr. Rajendra Singh Pardesi, sir, as I have already said, immediate past president of AMOGS, a very genuine, sincere person, very straightforward, and of course,
Yes,
always supportive to everybody.
Thank you.
Sir,
Dr.
over to you for the
Yes.
operation.
Good evening, everybody. Respected Chief Guest, Dr. Bhaskar Pal, our President-elect of FOXI, Dr. Kiran Kurtakoti, President AMOGS, and guest of honors, Dr. Arun More sir, Dr. Varsha Baste, then our past VPs, Dr. Ramani Devi, Dr. Girija Wag, and friends. First, I wish to congratulate convener Dr. Monica Umbardand and Dr. Sneha Bhuyar for organizing such an academic and practical webinar consistently with this 57th series of their, and with the galaxy of speakers like Dr. Ramani Devi, who will be speaking on heart disease in pregnancy, Dr. Girija Wag, she will be addressing on FGR, and Dr. Sneha Bhuyar on near-miss cases. With the panelists and chairpersons, I think all AMOGSians, I see all the people, our AMOGS people only. I think this is going to be a great event. I wish every success to Dr. Sneha Bhuyar for her future endeavor as Vice President elections, forthcoming Vice President elections. I wish every success to Dr. Monica Umbardand. She is contesting for the post of Chairperson, Public Awareness Committee, and wishing every success to this mega event. Thank you. Thank you so much for inviting me. Jai Sri Ram.
Thank
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 you.
you, sir.
Thank you so much, sir. Thank you for your blessings and all your guidance throughout, sir.
Yes. Now, it's time to hear from Dr. Arun More, but Saiti, can you please play his video? Actually, Arun More is a very dear friend of ours, and he's the Dean of Government Medical College. Parag, me and Arun, we have learned together, grown up together, but he's traveling, he's in the flight, he's going to his daughter's place, UK. So I think we'll just play a short video here, just wished in few seconds. Saiti, can we have the video?
Madam, she has
Yeah.
shared. Yeah, I will.
Yeah, Pratibha, can you please share from your end?
Yeah,
I'll just take it on my this thing.
yeah, please.
Just a minute.
He's also a very simple and genuine person, always very supportive. So just with few seconds, I think he has expressed his views. Can you play, Pratibha?
I have to start screen sharing, right?
Yeah, yeah.
Yes.
Share.
Good evening, friends. I thank the Emergency Obstetrics Committee for giving me this opportunity, and also Dr. Sneha for giving me this opportunity for this webinar on important topics, which includes heart disease in pregnancy, near miss cases, and FZR. I'm sorry that I will not be able to attend this webinar live because I will be in transit in flight during that time. I know Dr. Sneha from my undergraduate and postgraduate days. She is very sincere and hardworking. She is also doing very good job for Foxy, and hence I request you to vote for her in forthcoming election. Thank you.
Okay, should I stop?
Yes.
Yes, stop sharing, Pratibha.
Yeah. So thank you, Pratibha, for sharing, and thank you, Dr. Arun. Of course, we will convey your thank you for your wishes as well. So with the blessings of God Almighty and the blessings of our respected seniors, Chief Guest Dr. Bhaskar Pal and Dr. Kiran Kurtakoti, Guest of Honor Dr. Rajendra Singh Pardesi, Dr. Varsha Baste and Dr. Arun More, we would like to move ahead with the academic session. Once again, I thank all of you. And of course, I have already welcomed Ramani Madam. Madam, I welcome you once again. And we are here ready with the academic session. Monica, I think we can go ahead with the introduction of chairpersons. Thank you.
Thank you, ma'am. Can we have the CV slides, Saiti? The next slide, please. I would take privilege in introducing our chairpersons for the first session, Dr. Neha Lad, madam. She is currently the president of the Nashik OBGYN Society. Has been the past vice president and the clinical secretary of the same. She has been awarded the Dr. Vasantrao Gupte Award for the Best Doctor in 2022 and the Sayadri Puraskar, the Dronacharya Award by the Indian Society of Assisted Reproduction 2024. She is also an MS Signature Awardee and the Hirkani Award. We welcome you, ma'am, as a chairperson for the first session today. Dr. Narendra Zope, sir, is currently the president of the Dhule OBGYN Society. He also has an ICMR genetic course from the SGPGI Lucknow. We welcome you, sir, as a chairperson. And Dr. Jitendra Gumre, sir, is the president of the Dhule OBGYN Society. We welcome you, sir, as a chairperson. And I would request Neha, madam, or Zope, sir, to please introduce Ramni, ma'am, for the talk. Madam is going to speak about heart disease in pregnancy.
Monica, just take, otherwise you can start introducing.
Sneha,
Yes, ma'am.
I think no introduction. Let us
No
straight
worries.
away move on.
I will just introduce Madam. She is the president,
Yes, ma'am.
TNFG at present, and she was the National Vice President, Foxy, in the year 2020. She International Advisory Board member of Fertility Society of Bangladesh, and she was the ICOG Governing Council member 2018 to 20, Managing Director of the Ramakrishna Medical Center, LLP and Gen Fertility Center. Madam has got lots of awards and accolades, and of course, she's a thorough academician and lots of publications to her credit. Endometriosis is Madam's, forte, but yes, she speaks excellent on any topic. So, Madam, we are very happy to have you and listen to you. Over to you, Madam.
Thank you, Sneha, for your kind introduction. Let me share my PPT. Just hello.
ಇದು ಬೆಸ್ಟ್ ಒಂದು ಕಾನ್ಸೆಪ್ಟ್
Is my screen seen visible?
Yes, ma'am.
Yes.
Okay.
Yes. And
First of all, let me congratulate AMOGS Society for having constantly conducting such very nice webinars, as Dr. Rajendra Singh Pardeshi has already mentioned and Bhaskar Pal has mentioned. Always your programs used to be highly academic, and my regards to Dr. Kiran Kuttikodi, Dr. Rajendra Singh Pardeshi and all the senior members of AMOGS, and my respected chairpersons. And first of all, I wish Dr. Sneha Boyer a grand success this time. I am very sure you will come out with a grand success. And Dr. For Monica also, all the best. So with this, I start my talk on cardiac disease in pregnancy. The incidence varies between 0.1 to 4%. On an average of 1% of all the pregnant women are likely to have heart disease in pregnancy. Pregnancy with the heart disease has actually increased because earlier and there is also a reversal of rheumatic heart disease versus congenital heart disease. Now we have a higher incidence of people with congenital heart disease becoming pregnant because they have a long period of, long lifespan. And again, in developed countries, rheumatic heart disease is decreasing and congenital heart disease is increasing. And again, we should say maternal mortality rate due to heart disease overall has decreased, but in developing countries, there is relative increase in the maternal mortality rate. It has increased from 7.2 to 17.2 because we all of us know the most important causes of maternal mortality, probably the postpartum hemorrhage, anemia, and all those things have comparatively, they have been reduced. So ultimately, the incidence of heart disease having maternal mortality has increased. Why there's an increase in the maternal mortality rate in heart disease complicating pregnancy? One is the patient has advanced maternal age. Women who have, especially who have conceived through ART, they have an advanced maternal age, and they have higher incidence of comorbidities like diabetes, hypertension, and cardiac disease. I mean, women with congenital heart disease, they reach the age of reproduction because of wonderful surgical procedures what they undergo. Simple procedures, not only an open heart surgery, but through angiography, they are able to get their AST, VST, all the things corrected. And there is again an racial and ethnic variation. We always find that in Black women, the incidence of maternal mortality is quite high and highest in Black non-Hispanic women compared to the Hispanics. So this is the US national maternal death rate in 2011 and 2015, where they found out that heart disease and stroke caused more than 1 in 3 deaths, and within 1 week to 1 year postpartum, 33% of the maternal death occurs, and during pregnancy, 31%, and 36% at delivery or 1 week later. Black and American Indian, Alaskan Native women were about 3 times they are likely to die from pregnancy-related cause rather than any white woman. So then again, the normal and adverse cardiovascular clinical symptoms and signs during pregnancy. One is usual symptoms and signs of pregnancy. They have breathlessness on exertion,
intermittent palpitation, mild fluid retention, mildly elevated JVP, third heart sound, soft systolic murmur, resting tachycardia. All these things are somewhat we commonly see during pregnancy, but they should not be taken as signs and symptoms of cardiac pathology. But we have specific symptoms and signs suggestive of cardiac pathology. They are extreme breathlessness, chest pain, orthopnea, paroxysmal nocturnal dyspnea, nocturnal cough, when the tachycardia exceeds more than 100 beats per minute, fourth heart sound, harsh systolic and diastolic murmurs, and pulmonary edema, pleural effusion. These are all some of the signs and symptoms suggestive of cardiac disease. The types of cardiac disease are: one is coronary artery disease, second one is valvular heart disease, third is congenital heart disease. It can be arrhythmias or heart failures and muscular disorders. These are all the common types. And again, according to the etiology, it is classified as congenital cyanotic or acyanotic heart disease. It can be acquired rheumatic heart disease, cardiomyopathies or congestive cardiac failure, ischemic heart disease or myocardial infarction, hypertension, cerebrovascular disease, arrhythmias, and then thromboembolic disorders and hypercholesterolemia. So this is the common slide which we see in any heart disease and pregnancy presentation. That is the hemodynamic changes which occurs during normal pregnancy, where we expect the plasma volume, cardiac output, heart rate, MAP, stroke volume to raise, whereas the vascular, systemic vascular and the pulmonary vascular resistance falls down. And this gives the pictorial representation of the same. What are the symptoms of heart disease? They can have jaw, neck or chest pain, back pain, shortness of breath, then fainting, nausea, vomiting, indigestion, extreme fatigability, and discomfort are in the epigastric region. So the clinical findings are: clinically, the patient may have dyspnea, she may have cyanosis, clubbing of the fingers, and persistent neck vein distension, that is increased JVP. There can be systolic murmurs of grade 3 or 6. Any diastolic murmur is it is abnormal during pregnancy. They can have cardiomegaly, persistent arrhythmias, and persistent split of the second sound. So ECG and echocardiography are the two important modalities for diagnosed cardiac disease during cardiac disease. So then X-ray chest, it may show cardiomegaly and vascular prominence. Cardiac catheterization is rarely done during pregnancy. ECG will tell us the electrical pattern, and the mechanical thing is being can be picked up by the echocardiography. So then comes the cardio-obstetric model care. So now we are developing a subspecialty in obstetrics that is called as a cardio-obstetrics, where it involves a team of members like an expert cardiologist who is or a physician thorough in cardiovascular medicine, maternal fetal medicine, obstetrician, primary care consultant, anesthetist, nursing, pharmacy, social work, and other specialists. So together they form the cardio-obstetric team. So the cardio-obstetric model care, when should it start functioning? It should start pre-conception. The patient who is found to have a known cardiac disease should have a preconceptional advice like optimize the medical status prior to planning pregnancy, get clearance from the cardiologist, and risk assessment according to the WHO model. Corporate index and Sahara index should be calculated, and they should be clearly counseled regarding the chances of having an adverse pregnancy outcome as well as maternal-fetal outcome. So if they have any problem, and if it is a correctable one, preconceptionally, all these things can be corrected. And during pregnancy, team-based care with the patient, serial monitoring, delivery planning, balancing maternal and fetal risk should be there. Labor and delivery. Mode of delivery, ideally vaginal delivery is preferred, except in certain conditions where the cardiac condition needs surgical delivery. Regional anesthesia is ideal. You should monitor pulse with the patient with the pulse oximetry, telemetry if indicated. Then again, during the postpartum period, they should be monitored for a period of 48 hours till all the hemodynamic changes revert back to the pre-pregnancy stage. This period is very, very important because there is a chances of fluid overload shift during the immediate postpartum period, and assess and treat the cardiovascular complication patient's counseling and symptoms of the complication should be done. And in the 4th trimester, that is the 3 to 7 days follow-up post-discharge, comprehensive evaluation should be done within 6 weeks. Consider addition of telehealth visits and proper contraception should be advised. Not only that, this patient, they stop with the 4th trimester, but it can be extended on a long term. For example, a woman who has got an pre-adverse pregnancy outcome, for example, preeclampsia, hypertensive disorders, gestational diabetes, preterm delivery, small for gestational age, they are all at high risk of developing later onset of cardiovascular and cerebrovascular disease, and hence they should be advised to proper follow-up either at a local level or with a local physician, and if needed, cardiology department. So here, I would say that all the pregnant women who in Tamil Nadu are screened by echocardiography during the 1st trimester of pregnancy. This is very, as such, we have done more than 1,000 cases in our center, and we found out unexpectedly the incidence of cardiac problem, that is even a subtle problem like pulmonary, like small AST, VST, which the patient was totally unaware, and tricuspid regurg and everything is going to be found out at a higher incidence. And also doing echocardiography at an early stage will help us whether the patient can continue the pregnancy or get it terminated at an early stage. For example, a patient with a primary pulmonary hypertension, she may not be able to tolerate the pregnancy, and hence the ideal way is to terminate the pregnancy, and termination should preferably done during the 1st trimester. So according to the New York Heart Association, functional grading of the heart disease is class 1, 2, 3, and 4, where class 1, there is no symptom, normal physical activity, normal functional status. But whereas in class 2, the patient will have mild symptoms, they are very comfortable at rest, but slight limitation of the functional status is there. In class 3, there are moderate symptoms with less than normal physical activity. They are comfortable only at rest, and marked limitation even of the functional status. Even for the minimal work, normal less than normal physical activity, they may have exertion. Then class 4 is with severe symptoms where features of heart failure with minimal physical activity even at rest, and severe limitation of the functional status is there. Now, classification of heart disease during pregnancy according to risk. See, there are some heart diseases. Not all heart diseases have a high risk, but they can be again divided into low risk, medium risk, and high risk. Low risk is the one that where the maternal death is less than 1%, AST, VST, PDA, mild mitral stenosis, and corrected fallows. Medium risk is about 5 to 15% of death, where mitral stenosis of moderate to severe intensity, mitral stenosis with atrial fibrillation, aortic stenosis, uncorrected fallows tetralogy. Very high risk or up to 50% maternal mortality can happen in pulmonary hypertension, Ising-Mengers, aortic coarctation with a valve involvement, and Marfan syndrome with the aortic root involvement. So this is the Cartwright index where you can calculate the predictor and the points given. So whether the patient has got a prior cardiac event or she belongs to a New York Heart Association 3 or 4 classification or cyanosis, presence of mechanical valve that has got a higher score, ventricular dysfunction, and high-risk left-sided valve disease, and left ventricular outflow tract. Always remember all stenotic lesions are worse than a incompetent lesions, pulmonary hypertension, CAD, high risk of aortopathy, where the aortic root dilatation is beyond 4.5 centimeters, no prior cardiac intervention, and late pregnancy assessment. So then comes another score that is called as a Sahara score in pregnancy, where the predictor and the points are given here with a total point of 0 to 13. So here, if the total point is 0, then she has a risk of 2.9% MMR, and 0.5 to 1.5 it is 7.5%, 0.5 to 2.5 it is 17.5, 2.5 to 3.5 it is 43, and beyond 3.5 the risk is 70%. So here you can see that mechanical valve processes, they have a higher risk, and then severe mitral stenosis and aortic stenosis, they have high risk of developing problems during pregnancy. So then WHO has modified classification into 1, 2, and 3, where the patient with the previously diagnosed hypertension, diabetes, with morbid obesity successfully repaired simple lesions like AST, VST, uncomplicated small mitral valve prolapse, pulmonary stenosis, palpitations, and no dizziness as classification under 1. Under 2, unoperated AST, VST, repaired phallostetrology, coarctation, arrhythmia, and dizziness, mild left ventricular impairment where the ejection fraction is greater than 45%, and New Heart Association classification is 2 due to newly diagnosed peripartum cardiomyopathy or hypertensive heart failure. Previously diagnosed rheumatic heart disease with murmurs and recently assessed symptomatic mechanical valve, asymptomatic mechanical valve, all those people, they come under group classification 2. Classification 3 and 4, mechanical valve patients with symptoms, complex congenital cyanotic heart disease, pulmonary hypertension of any cause, previously diagnosed PPCM, and when there is severe ejection fraction reduction less than 45%, tight mitral and aortic stenosis, and the aortic dilatation is more than 45 millimeter, either as we see in Marfan's or bicuspid aortic valve. So now let us see what is the effect of heart disease upon pregnancy and vice versa. Upon pregnancy, the patient can land up with abortion, preterm labor, IUGR, teratogenicity, could be drug-induced, congenital heart disease, especially when the mother has got a congenital heart disease, the baby has got a chance of 5% intrauterine fetal demise, and on the maternal side, worsening of the cardiac status, CCF, bacterial endocarditis, pulmonary edema, pulmonary embolism, rupture of aneurysm, and no long-term effect on the basic defect we should understand. Now, what are all the critical periods during antenatal period where we have to have more vigilance towards these antenatal mothers? It starts right at 6 weeks. That is what I am telling. Even in the first trimester, we should try to do an echo and then detect whether she is not a cardiac patient, or if she has a cardiac problems, then we should assess under which category she falls. Then the maximum hemodynamic changes occurs around 30 weeks. Then intrapartum period is again a critical period. Just after delivery, up to 48 hours. And the second week, up to 2 weeks, it is very, we have to have a careful mark. And of course, the patient needs a long-term follow-up. So what are the poor prognostic indicators? First thing is history of previous adverse effects like heart failure, ischemic heart disease, stroke, arrhythmia patients who are on anticoagulants, mechanical valves, NYHA as class 3 and 4, and mitral valve area below 2 square centimeter and aortic valve area below 1.5 to 2 square centimeter, and the ejection fraction when it is less than 40%. Additional risk factors. These are all some of the correctable risk factors like anemia, which can be easily corrected, infections, hypertension, which can be controlled, physical labor, we can restrict the patient to undergo severe physical exercise. Weight gain should not be more. It should be a reasonable weight gain. Higher degree of weight gain and a basic obesity will tilt the balance, and multiple pregnancy that is not avoidable probably in patients with a ART, or when it is early diagnosed, we can go in for a feticide or a fetal reduction, and then caffeine and alcohol intake can be prevented, pain and drugs. Tocolytics should be avoided in all these patients. So preconceptional counseling I have already discussed. Obstetrician with a primary care physician, cardiologist, and emergency room physician. It should be a referral team to the cardio-obstetric team where the patient should undergo echocardiogram, NT-BNP testing should be done, and Holter monitor whenever it is indicated, and a teamwork of the maternal-fetal medicine consultants, anesthetists, cardiologists, pharmacists, social worker, everybody should be involved in that. So the cardiac team, and you should have a shared decision making between the consultants and the patient. Patient should be allowed to discuss their problem and their need to continuation of the pregnancy, and the consultant should tell them that what are the complications they are likely to have. And all the medications preconceptionally what she is taking, that should be reviewed. For example, we cannot permit the ACE and ARB inhibitors if they are on those drugs for hypertension. And oral anticoagulant, there is a slide in the concept that oral anticoagulants can be continued even during the first trimester, but that should be within particular milligram of the drug. And folic acid supplementation and correction of anemia, B12 supplementation, other micronutrients should be given. Antenatal care, clear counseling, and every 2 weeks, they should visit the consultant up to 30 weeks. And probably at 30 weeks, if she falls under a high risk category, she has to get hospitalized. And every visit, you have to note the pulse rate, blood pressure, cough, dyspnea, weight gain, anemia, and auscultate the lung basis for the pulmonary edema, re-evaluate the functional grade. That is very important because the person who is found to have a grade 1 or 2 functional grade of a New York Heart Association may increase to grade 3 or 4 and ensure treatment compliance. And then we have to definitely have a fetal echo at 20 weeks because the mother who has got a congenital heart disease, the child has a 5% risk of developing congenital heart disease. Fetal monitoring, and suppose if the patient is undergoing, the chances of preterm birth is going to be high, then probably for correction, we can give atazibon, which is much better than nifedipine. But again, we know the cost of atazibon is quite exorbitant. And the special advice is, advise them to take adequate rest, and they cannot strain too much. It should be within normal limit. Proper diet, iron, vitamins, proper hygiene, especially dental care is very important. Restriction of salt, 4 to 6 grams per day. Avoid smoking, drugs, beta mimetic. Avoid air travel and get adequate sleep. That is very essential. Early diagnosis and treatment of PIH and infection, and therapeutic and prophylactic cardiac interventions are applicable. For example, if the patient is found to have a mitral stenosis, which is found to be tight during the first trimester, it is always safer for the patient to go for a mitral balloon valvuloplasty during the mid-trimester because it will totally make the hemodynamic changes that can be reversed. And the patient post balloon valvuloplasty patient, they have a very good outcome in the subsequent trimester. Then again, benzathine penicillin, we all of you know that we have to give for prevention of recurrence of rheumatic fever. Enough of diuretics, beta blockers preferably avoided, digitalization and anticoagulants in patients who are on mechanical valves, and then surgical treatment. That's what I said, balloon mitral valvuloplasty can be done. Then management of preterm labor is admit the patient for hospitalized. No beta mimetic, no nifedipine, atazibon can be safe. Steroids, follow the patient protocol of preterm labor. In utero transfer to a tertiary care center is ideal. Late preterm as per cardiac protocol we can do. For example, if the patient has got 32 or 34 weeks, the patient can be delivered in the local place according to the cardiac protocol. So now comes which patient should be delivered in which area. For example, according to WHO, class 1 and 2, patients who are having mild pulmonary, that is class 1, we have already described pulmonary stenosis of mild and small one, PDA, small and mild, MVPS, and successfully repaired shunts like AST, VST, PDA. And all these patients, they can have periodic assessments like once in 15 days, and they can have a delivery at a local hospital under proper maternal and fetal care centers. Then WHO 2 classification, unrepaired AST, VST, repaired fallows, Turner syndrome without aortic root dilatation, and follow-up should be definitely they have to have a regular follow-up, and preferably they can have a delivery at a local center. But when it comes to class 2 to 3, where there is mild LV, left ventricular impairment, but still the ejection fraction is greater than 54%, and a native or a tissue valvular disease, and Marfan's aortic root dilatation less than 45 millimeter in bicuspid valve, and repaired coarctation and corrected VST, all these patients can be followed bi-monthly in an expert center and delivered in an expert center. Then class 3, where there is severe LV dysfunction, mechanical valve, and Fontane's procedure, and then unrepaired cyanotic heart disease, moderate mitral stenosis, severe asymptomatic aortic stenosis, and moderate aortic root dilatation, they should be followed up, and probable delivery is in an expert center. Now, when should you get the patient admitted? Elective admission, according to in class 1, 2 weeks before EDD. In class 2, it should be between 28 to 30 weeks, where all the hemodynamic changes occurs at the peak. And class 3 and 4, irrespective of the period of gestation, as soon as the patient comes, it is better you get the patient hospitalized and observe her. To change from oral anticoagulants to heparin in early pregnancy, again 36 weeks in patients on anticoagulants. This has got a slight modification, which I can discuss later. Indication, emergency admission is deterioration of the functional grade, then symptoms and signs of complications like fever, persistent cough, basal crypts, tachyarrhythmias, anemia, elevated JVP, infections, PIH, abnormal weight gain, and other medical indication. Then during labor and management, only institutional delivery. Induction of labor is only for obstetric indication. Intracervical Foley is ideal for congenital heart disease. PG gel may be employed, but it should be used with caution. Preferably, I always prefer an intracervical Foley installation for labor induction in cardiac patient. So how should you manage in the first stage of labor? Confined to bed, propped up or semi-recumbent, oxygen SOS, sedation, epidural will be ideal. Cautious use of IV fluids, not more than 75 ml. Stop anticoagulants at least 6 to 8 hours prior to the induction. Digitalize if the patient has got CCF. Diuretics, bronchodilators, endocarditis prophylaxis, and continuous cardiac monitoring with pulse oximetry, and if available, pulmonary artery catheterization for continuous hemodynamic monitoring. Of course, we need at least a definitive cardiac monitoring with the pulse oximetry and evaluation of the anesthetist and cardiologist, preferably in a setting up of HTU or ICU, she should be kept. Then endocarditis prophylaxis can be given for, it depends. Now we have a selected list of patients who need to have endocarditis prophylaxis, for example, rheumatic heart disease, prosthetic valves, patients on hemodialysis, immunosuppression, and patients who are put on long-term intravenous catheters. So bacterial endocarditis prophylaxis is not recommended for all. It is only at risk of infection and severe lesion. Either we can give ampicillin with gentamicin, or if allergic to penicillin, you can give vancomycin or clindamycin plus gentamicin can be given. Then management of second stage of labor. Delivery should be in a propped up or a semi-recumbent position. Avoid forceful bearing down. Adequate pain relief by epidural and pudendal block. Cut short the second stage by using episiotomy, vacuum forces, but not always necessary. But there should be a strict cardiovascular monitoring. Then third stage, follow Amstel. Use only oxytocin IM, no carbitocin. Avoid bolus syntocinon, ergometrin, and carbitocin. Propped up oxygen inhalation. Furosemide should be given immediately after the delivery of the fetus on the placenta, because that will help in diuresis and helps to reduce the preload to the heart. Then adequate analgesics can be given. Watch for signs of congenital heart failure, pulmonary edema. Treat PPH energetically. Ideally, mechanical methods were like bimanual compression, or I think the most preferable one, easiest one nowadays available is SR cannula, because that gives a better, most effective PPH control rather than the drugs which may be contraindicated during cardiac condition. And Beeling seizure, if you are doing an LSCS, and misoprostol may be better than carboprostol. And first hour during delivery, first 3 hours, patient should be watched very carefully. Oxygen SOS, watch for signs of pulmonary edema, sedation, and proper antibiotic. Now, coming to LSCS, it is only, when should you do it? It is only obstetric, but in patients who has got a coarctation of aorta, where the root dilatation is more than 4.5, Marfan's, prefer epidural analgesia for these patients, or narcotic conduction analgesia, general anesthesia in pulmonary hypertension, and patients who are having intracardiac shunts. Advice at the time of, and the postpartum period is management is the same like any other patient, and like a patient who has even delivered normally. So advice at the time of discharge is continue medical treatment, avoid infection, reassessment after 6 weeks or earlier. If some complication occurs, we have to supplement the patient with iron, prevent anemia. Cardiological consultation for definitive management is needed. Promote breastfeeding, and adding proper contraception should be advised. Postpartum red flag signs are when the patient has got chest pain, dyspnea, orthopnea, cough, edema, tachycardia, non-vagal syncope, headache, visual changes, hyper or hypotension. They are all red flag signs which should warn the physician. Then the fourth trimester is very important. Again, that is be extended beyond the third one, fourth trimester, where we have to physically assess everyone, every parameter like physical examination, blood pressure, cardiovascular symptoms, and mental health is also very important. And the patient should get adherent to the medication, lactation support, family planning, barriers to care, social support, establish primary care, longitudinal assessment of CVD risk factors. Then lactation, the patient may have stress and fatigability, but proper advice and family support should be given, and long-term complications of adverse pregnancy outcome should be explained to the patient, and physical activity, they should be counseled regarding the early physical activity and management, and treat on the long term. We have to treat properly hypertension, diabetes, and chronic CVD management, mental health disorders, referral to social services and primary care physicians, and then screening for diabetes, hyperlipidemia, and proper contraception, and they should see also a nutritionist. So postpartum complications are cardiomyopathy, left-sided valve stenosis. All these conditions will increase the risk. Pulmonary hypertension, hypertensive disorders. Again, potential cardiovascular complications are heart failure, stroke, thromboembolism, aortic dissection, hypertension, and then arrhythmia and coronary dissection. And suggested monitoring is like any other patient. We have to monitor a routine patient in the routine cardiac patient in the post-operative period. Now, let us see who are the patients with cardiac conditions who should not conceive. The severe primary pulmonary hypertension is one absolute contraindication where the patient cannot conceive, and Eisenmenger syndrome, and class 3 to class 4, and severe obstructive cardiac lesion when the Marfan syndrome with the aortic root dilatation is beyond 40 or 45, severe stenosis, peripartum cardiomyopathy in the previous pregnancy with persistent LVD or a serious episode of heart failure during the previous pregnancy. They are not candidates for subsequent pregnancy. Then medical termination is indicated in diseases where pregnancy is contraindicated, what I have mentioned earlier. Preferably, it should be done in first trimester. Suction evacuation is ideal, and medical termination of pregnancy also carries slight risk. Then cardiac contraception, barrier contraception, and progesterone, DMPA or Norplan, intrauterine UCD is not contraindicated. COCs we do not give, and sterilization, both male and female sterilization can be suggested. And this is a chart to say this or reasonably they can accept these sort of like IUCD, implants, DMPA, progesterone only pill, and combine. So this combined CHCs. This U is definitely it is contraindicated, or is conditions where you can use them safely. This is given in the net, you can search it. Then among the congenital heart disease, this is the second group of patients. We have to understand what are the basic congenital heart disease the patient has got, and accordingly we can advise them. For example, if the patient with a minor AST or VST, they can go ahead with the pregnancy without any problem. And this hemodynamic and vascular changes that are happening during the pregnancy can exacerbate the problem. Obstetric pathologies, superadded pathologies like preeclampsia infection can tilt the balance. Cardiac outcome, there is increased risk of cardiac failure, arrhythmia, and thromboembolism. Most important thing is the patient's maternal cardiac patient, congenital heart disease patient, they have a 5% chance of the baby also developing congenital heart disease, and it should be monitored, and the cardio obstetric team should work together to have a better outcome. So this is a chart to show the valvular heart disease. As I have mentioned earlier, patients with the stenotic lesions, they are at high risk of developing cardiac complications like acute fulminant pulmonary edema, and regurgitant lesion, reasonably they do very well. And prosthetic valve, among the prosthetic valve patient, bioprosthetic valve is very safe, but a patient with the mechanical valve, they have to have definite protocols during maintenance of this anticoagulants. So bioprosthetic valve patients, they need no anticoagulant. They should have all these patients with a prosthetic valve, they should have a preconceptional counseling, evaluation, change from heparin to oral anticoagulant, proper AN care, change to an oral anticoagulant care in the mid-trimester. Then prior to delivery, they can get admitted and change back to heparin and delivery in a tertiary care center. Again, now we have come to understand that if the patient is using a warfarin less than 5 milligram or phenoprocumarin less than 3 milligram, then these patients, they can continue the same drug and there is no need to get changed to low molecular heparin. But periodically, once in 15 days, they have to monitor their PT INR. So that can help to maintain the anticoagulant status within a proper timing. But when the dosage of the warfarin is greater than 5 or coumarin is greater than 3 and azinocumarol is more than 2 milligram, probably these are the candidates who need to convert to low molecular weight heparin or unfractionated heparin, and then they have to carry through the first trimester. Then in the mid-trimester, they can change over back to their oral anticoagulant. And again, nearing delivery, they should, by 36 weeks, they should get admitted with the proper evaluation of APTT and PT. And then we can shift once again from oral anticoagulant to either to unfractionated or LMWH, and delivery should be done. And before 4 to 6 hours prior to planning delivery, stop the anticoagulant, and it can be again restarted 6 hours after delivery. So this is another group of patients whom we come across, because these women who are undergoing ART are at a later stage and they have some hidden ischemic heart disease which gets manifested during pregnancy. Hence, they have an added burden and they are at high risk of developing maternal morbidity and mortality. So it is always safe to evaluate the patient with increased maternal age. For example, say beyond 40 years, thoroughly investigate the patient, ruling out by doing an ECG, echo, and clinical assessment, and then rule out ischemic heart disease. And again, they are at a risk of developing preeclampsia, preterm labor, and increased maternal morbidity and mortality. And these group of people are all, they should be monitored by a multidisciplinary team. And I had the opportunity of witnessing one patient who came to me at 42 years of pregnancy with severe chest pain. She was having a period of 4 months of amenorrhea. She thought it was just an amenorrhea. On examination, she was found to be 16 weeks with pregnancy with myocardial infarction. And we have to give the priority to myocardial infarction. And she was thrombolized, and later she was stabilized, and then she had the MTP done. Then heart failure during pregnancy is another big problem. Probably this occurs. The commonest cause is cardiomyopathy of any cause. And very rarely we get congenital heart disease and valvular heart disease, and again ischemic heart disease. So the common thing is only cardiomyopathy. So this patient, you have to have heart failure patient. They have to get modifiable risk factors should be modified. Obstetric factors like eclampsia, preeclampsia, hypertension, and placenta previa abruption, multiple gestation, they are all increasing the risk. And again, there should be contraindication, should be coronary artery disease, severe WHO class 3, class 4, pre-pregnancy heart failure and associated renal problem and severe diabetes, and the ethnic population. So the adverse maternal outcomes associated with heart failure that increases the maternal death, prolonged hospital stay, increased incidence of cesarean delivery, pulmonary edema, acute renal shutdown, and cerebrovascular disease. So these are the poor indicators, prognostic indicators I have mentioned earlier. So the management of heart failure is they have to be identified and optimize the preload, proper oxygenation, inotropic supports, and then vasopressors if needed. And if the patient is unstable, deliver the patient as far as possible. If the patient is stable, then we can antenatally treat the patient with vasodilators and then hospitalize and consider the mode of delivery. And in the postpartum period, like any other non-pregnant woman, you can manage heart failure with AC inhibitors, ARBs, and then diuretics, and consider bromocriptine is emerging as a new drug in the management of postpartum cardiomyopathy. Then pulmonary embolism, I think this is a separate chapter on its own. And peripartum cardiomyopathy is also a separate topic. So now coming to pregnancy with a cardiac pacemaker, we now come across a lot of patients with cardiac pacemaker, which is put to them and because of arrhythmia and the history of arrhythmia or antiarrhythmic drugs, anticoagulation. If the patients have got arrhythmia, ideal is to put them on anticoagulation and then acute management of arrhythmias and consider ablation of the nodes for refractory condition. So a patient who's stable with a cardiac pacemaker, generally they do not have any problem during delivery, but they should be monitored carefully by a cardio-obstetric team. And postpartum follow-up, contraception is most important thing. That is immediate postpartum monitoring is important. Then coming to the contraception, we have already discussed, and future cardiovascular risk factors also I have discussed. Proper physical activity, weight loss, control, smoking should be avoided, alcohol should be avoided, BP to be maintained, and then blood glucose to be maintained, and prophylaxis in the form of low dose aspirins can be given. And if they have a cardiovascular risk factor, they can be aggressively assessed and they can be either medically or surgically managed. And ideal is for few of the cases whom I have already mentioned, ideal is not to go for a subsequent pregnancy. So this is once again, I'm telling there is increased risk of long-term cardiovascular problems like IHT, stroke, heart failure, and DM as the patient has got adverse pregnancy outcomes like preeclampsia, hypertension, diabetes, preterm birth, and small for gestational age. So this is one area which is of interest to me. Patients, we can assess, we can call back the patients with a previous history of adverse effects during pregnancy and find out how many of them are having some cardiac assessments or the vice versa. In the cardiac department, we can inquire how many of these patients had adverse pregnancy outcome. So ultimately, this is a teamwork which can help to prevent the patient having morbidity and mortality. So the ideal thing is save the heart from pregnancy, save the pregnancy from the heart, and ultimately save ourselves. This is the message I would like to give. And once again, I thank Dr. Sneha Buyar for giving me this opportunity to discuss the cardiac disease in pregnancy, which is one of my favorite topics. Thank you, Sneha and Monica. Wish you all the best. Thank you.
Thank you, madam.
Thank you, ma'am.
That was really very great.
Pratibha,
Any
you,
comment from the chairperson?
That was an excellent and exhaustive talk, I would say. Lots of take-home messages, really, that is very, very helpful for all the practicing obstetricians. With this, we would like to thank Madam Ramani Devi. Any comment from the chairpersons? Or I think
ma'am, actually nobody has renamed, so I cannot understand who was joined in without.
Never mind. We can
Neha
ask
Lal and Dr.
Pardeshi sir to make few comments.
Pardeshi sir, please unmute yourself.
It was really a nice talk by Dr. Ramani Devi. Ramani Devi is really stalwart in. She can give. She is known to as a endometriosis lady, but I think she is an all-rounder. She really narrated all the conditions, heart disease, and in pregnancy, and with their antenatal management also, and during intrapartum also. Thank you, Dr. Ramani Devi.
Thank you, sir. Thank you.
Thank you, sir.
Thank you, ma'am. Thank you for your blessings also. For me and Sneha ma'am both, we both need ma'am. And I request Pratibha to please continue with the second academic talk.
Yeah. So we move ahead with session 2 for today, which is management of fetal growth restriction. I invite for the same the chairpersons for today, Dr. Gauri, who is a chief consultant at Sahyadri Super Specialty Hospital. Can I have a, yeah. She has done her MBBS and MS, and she has done her MBBS and MS, and she's a chief consultant at Sahyadri Super Specialty Hospital, Nashik. She mainly manages the high-risk pregnancy unit as SSH, and she's a consultant at Purandare Hospital and Subhashri Clinic. I welcome you, Dr. Gauri, madam. Our next chairperson for today is Dr. Tushar Zambre, sir, who is the president of Malegaon OBGYN Society, practicing since 1999, and the director of Yash Hospital and Maternity Home. I welcome you, Tushar, sir. The other chairperson for today is Dr. Ujjwala Deore, madam. She manages Siddhivinayak Medicenters Private Limited from Chalisgaon, and she has been a member of Rotary Club and Indian Medical Associations. She has received President Appreciation Award from IMA Maharashtra and from IMA branch Dhule. She has received the Sri Shakti Gaurav Prime Focus Samman 2018, Foxy Appreciation Award 2024. She has conducted many awareness camps, and she's working as a mother,
So-
doctor, and social activist.
Yeah,
Thank
yeah.
you so
She's
much,
also
Deore,
the-
madam. Please.
She's also the master trainer for HPV vaccination by Fox
Okay.
IMA. So we welcome you, Madam Ujjwala Devre, and we go ahead with the. Please introduce Dr. Girija Wagh, our speaker for today.
Yes, ma'am. I hand over the mic to the chairpersons. They can conduct the session.
So,
Yes,
anyone,
Deore, madam. You are audible now.
good evening and thanks for giving me the opportunity to introduce Dr. Girija Wagh, ma'am. So she is a professor and HOD Department of Obstetrics and Gynecology in BVDTUMC Pune, and she is the director of Prime Rose Wellness and Care. She has so many professional highlights: veterinary gynecologist and medical consultant. She has leadership roles, former VP for Foxy, chair for medical disorders in pregnancy committee, and national mentor for Laksha and academic and researcher contributions, structurally medical workshop, refining research topics and guiding medical students, severe publications and author of chapters and books, and over 2,500 talks she delivered. Healthcare.
Okay, madam. It's okay.
Yes, yes.
Thank you so much.
And yes,
Welcome. Joshi Award for excellent. And
yeah, thank you, madam. Thank you, and we welcome our dear friend, veteran teacher, Dr. Girija Wagh. Over to you, my dear, for your talk.
Thank you so much for giving me that wonderful introduction and a platform, Sneha. It's really creditable that you have got all of us from the Nashik, Malegaon, Dhule, Chalisgaon societies together today and to discuss a very important topic like intrauterine growth restriction. My due respects to the chairpersons whom I found are experienced high-risk obstetricians, and I'm sure that is going to be a true challenge for me to deliver something which is going to be up to your expectations. Hopefully, I'm able to do the justice. Now, many times because of, I hope my presentation is seen.
Yes, very well.
Thank you so much. So we have now a great access to ultrasound and Dopplers, and then we also are understanding a lot of pathophysiology of the fetal growth restriction. And therefore, it's important that we keep on updating our knowledge so that we are able to deliver the best outcomes in the given challenges. When we look at fetal growth restriction, every fetus has a potential to grow, we are aware, and not only a potential to grow, they have a lot of sort of an reason, they are fighters, they want to grow and they want to survive. But when they fail to achieve this growth potential, then they become fetal growth restricted, and our challenges remain that, okay, fine, if they are FGRs, first identify them, diagnose them, treat them so that they are able to survive and have a good quality of life. So when we look at the statistics, the SMFM Society says that it occurs up to 10% of pregnancies and is second to premature birth as a cause of infant morbidity and mortality. We are very aware of this. And its significant perinatal impact is because it has an impact on long-term health outcomes. So today, when we are looking at youngsters getting myocardial infarctions, getting diabetes very early in life, we see that they have not reached the height potential, which probably the family averaging would be. The reason probably can be an intrauterine growth restriction. So another component also is the small for gestational age baby. And these are also something that we need to differentiate, and we are going to deal with this understanding. 52% of stillbirths are small. There is increased perinatal mortality, and 72% of unexplained fetal deaths are SGAs, which are less than the 10th centile of that particular growth potential which was necessary.
Naturally, since we are in India, it's very important that we know what is our country's statistics saying. When we look at the current birth rate is 17.8 births per 1,000 people. Perinatal mortality is 26 per 1,000 births, which is quite phenomenal. It ranges from 16 per 1,000 births in urban areas to 28 per 1,000 births in rural parts. And the stillbirth rate in India is 22 per 1,000 births, varies between 20 to 66. So when we have such a wide range, it's not a really nice thing to know births in different states. And the commonest cause of stillbirth is fetal growth restriction to the tune of nearly 28 to 30%. And therefore, it's very relevant. And I really thank Sneha, as she has always been an astute academician and a very contributory person to women's health at large and perinatal medicine. She has always picked up topics which are very essential for our day-to-day practice and are for benefit so that we can improvise. And as I speak about this, I request all of you to ensure that Sneha is supported this time and gets the coveted post of the Vice President of FOXI. So when we look at the impact of fetal weight, 26% of pregnancies in India, adverse perinatal outcome, abnormal long-term neurodevelopmental outcomes, long-term cardiovascular dysfunction, and metabolic syndrome are something which are associated when these babies are born, and they would have these later life disorders. Now, the nomenclature, we very commonly say intrauterine growth restriction. So while both the terms, IUGR and FGR, refer to the same condition, FGR is now the preferred and the more accurate term. And why so? Because IUGR is concerned as outdated, as it focuses on the restriction of growth within the uterus, while FGR acknowledges that the limitation can be a result of various factors affecting the fetus's potential for growth, both before and during pregnancy, and therefore fetal growth restriction is identified to be a better post. I have got a few cases while we are talking about it. Let's look at Sheila, 32-year-old primey, married for 5 years, was anxious to conceive, hypothyroid for 2 years on 50 mcg of thyroxine, a very common thing nowadays that we are seeing in our practices, has undergone ovulation induction in her previous cycle, but this time she conceived naturally. And her blood pressure is 120/80, body mass index is 30, which classifies her as class 1 obesity. Rest of the routine antenatal investigations are normal. GCT is 120 milligrams per deciliter, and ultrasound shows a 7 weeks live fetus, which corresponds to dates. So the question comes, is she at risk? Now, she wants to know whether she will need to come to further testing and frequency, and is worried as her sister delivered a small baby by cesarean birth and the baby needed NICU care for a month. So do all pregnant women need a risk assessment of FGR at booking, and risk factors to be looked for in assessment? And this is one of the most wonderful strategies that we can get in. Now, it's always a good practice to refer to guidelines, because if I say it as Dr. Girija Wagh, one will say, where is? Even my son will ask, what is the evidence, mother? So this is the reason why we put in these guidelines here. All women should be assessed at booking for risk factors for an SGA fetus or a neonate to identify those who require increased surveillance. And it's therefore logical and imperative that we be conscious about these risk factors. So this woman had class 1 obesity, hypothyroidism, and definitely a risk of developing placental abnormality, which can either lead to preeclampsia or it can give rise to preterm birth. It's open. So the risk factors in this particular condition, please come in, are minor, that is age more than 35, IVF singleton, nullipara, BMI. So you have to look at these minor risk factors: BMI less than 20 or more than 25 to 34, smoker 1 to 10 days, low fruit intake pre-pregnancy, previous preeclampsia, pregnancy interval less than 6 months or more than 60 months. And the major risk factors are age more than 40, smoker more than 11 per day, paternal SGA or maternal SGA. Sometimes now we do get these evidences. If she's using any substance use disorders, daily vigorous exercises, sometimes they do a lot of physical work, previous SGA baby, previous stillbirth, chronic hypertension, diabetes with vascular disease, renal impairment, APLA, and heavy bleeding. So early pointers can be in the first trimester serum markers as well. predict early onset FGR or preeclampsia, especially we are doing a combined testing at 12 to 13 weeks of gestation. And there if we find that the PAPE is less, or nowadays, since the last 3 or 5 years, I've started doing even PLGF in such high-risk mothers, they can actually help us in predicting preeclampsia and placental disease. And these would be most consistent in the second trimester. You can consider looking at the elevation of the alpha-fetoprotein and SCG are markers of abnormal placentation, and these are the ones who develop hypertension. So I bring you greetings from Bharati Vidyapeeth University Medical College, and despite being a medical school, we insist during our antenatal period, all those mothers who come to us, screening them for diabetes, hypothyroidism, sickle cell disease, and for combined testing. Of course, PLGF is not offered to all of them because they find it expensive. So in a low-risk patient, you could look at these very carefully when you're looking at the anomaly scan. Look at the growth parameters carefully. Serial symphyso-fundal heights estimation from 24 weeks, biometry at 32 weeks, and umbilical artery Dopplers at 32 weeks of gestation. Measuring the pubofundic height, looking at the growth charts, and looking at all the other things or associated factors can go a long way in identifying. So suppose let's look at one major risk factor. Suppose if Sheila has one major risk factor, then would your follow-up differ? So it's something that we need to risk tag these women. And with the one major risk factor, it's important to do an intensive surveillance from 26 to 28 weeks of pregnancy, serial ultrasound measurements for fetal size. Sometimes in the early part, maybe you've done an early anomaly scan, or you have done not an early anomaly scan, but the TIFA scan at 19 weeks. You have done a fetal to deco at 23 weeks, and you find that the femur length of the baby is shorter, while the rest of the parameters are fine. So many times it's been seen that this can be an early sign of fetal growth restriction, and maybe you have a little opportunity where you can, sort of try to help them. So serial ultrasound measurement of fetal size, assessment of well-being with umbilical artery Dopplers is something that we can consider. So what are we doing here? Fetal heart rate, placental position, BPD, HC, AC, and fetal femur length planes. So these are looked at through biometry. And from Doppler, normal uterine artery Dopplers, umbilical artery Doppler, MCA, aortic ischemic Doppler, and normal ductus venous Dopplers are the ones which can be considered, which can help us in identifying. Now, if the patient has 3 or more minor risk factors, then uterine artery Doppler at 20 to 24 weeks gestation would be a great parameter. And you can see here that this is something that can be looked at, and it can help us in showing that and you should, of course, put a proper angulation when you're looking at this and do it correctly. Now, uterine artery Doppler at 20 to 24 weeks of gestation, if it's abnormal, that is when the PI is more than the 95th centile and or notching, in higher risk populations, uterine artery Doppler has only a moderate predictive value. And abnormal uterine Doppler and subsequent normalization of low velocity indices is still associated with an increased risk. Repeating has limited value. And if abnormal at 20 to 24 weeks, referred for serial assessment from 26 to 28 weeks of pregnancy. If a normal uterine artery Doppler do not require serial measurement unless they develop specific pregnancy complications such as abruption or hypertension, and this should be offered a scan for fetal size and umbilical artery Doppler during the 3rd trimester. Now, if you have other major risk factors, a low level of PAPE, that is less than 0.415 moms, fetal echogenic bowel, or 2nd trimester Down syndrome markers, which have limited predictive accuracy value for delivering of an SGA neonate. So herein, now if one major risk factor, if 3 or more minor risk factors with abnormal uterine artery Doppler 20 to 24 weeks of gestation, reduced PAPE in 1st trimester, all these no risk factors but as abnormal uterine artery Doppler report, then serial assessment from 26 to 28 weeks is a good strategy. There have been identified several biomarkers, but not most of them are, it's unable to use them in our day-to-day practice and have always been in experimental windows. Now, when we look at definitions of fetal growth restriction, There's an ultrasound definition, there's a classification of growth by the birth weight percentile, and there's population-based reference range versus the customized growth charts is something that we have to look at. So the ACOG defines FGR as expected fetal weight on the less than centile percentile for that gestational age. HGA, newborn birth weight, is less than the 10th centile for the gestational age. And SMFM also includes AC, that is abdominal circumference of less than 10th centile for gestational age for fetal growth restriction. And SGA versus severe SGA less than the 3rd centile. Now, when we are looking at the classification, early onset FGR is the one which is less than 32 weeks. More severe disease course and more likely to be associated with placental insufficiency, hypertension, genetic disorders, maternal hypertension, Doppler abnormalities, and infections. Late onset, which is after or at 32 weeks, accounts for 70 to 80% of cases. Generally, it has a milder clinical course and without flow abnormalities. But then severe fetal growth restriction can be there when the expected fetal weight is less than the 3rd centile, and this would be consistent with a more severe form of fetal growth restriction, and that is how we have to look at it in a clinical perspective. Now, this is a screenshot that I have got to you about the International Journal of Infertility and Fetal Medicine published in 2022, which is a stage-based FGR, and they have done a wonderful study of perinatal outcomes in SGR and FGRs. And this is definitely worth a reference, and I would request you to really go through this because this has been published from the Fernandez Hospital, Hyderabad. So when we look at this stage-based classification of fetal growth restrictions, stage 1 is severe smallness and mild placental insufficiency, where the EFW is less than the 3rd centile, CPR is less, uterine RTPI is more than the 95th centile, umbilical RTPI is more, and then there is increased pulsatility index in the carotid artery. Monitoring should be done weekly. They've also given a wonderful management processing as well there. So then you can consider how to manage them. So at 37 weeks, it's always prudent in these patients to deliver them and do a labor induction. If there is severe placental insufficiency, this is stage 2 classification. When uterine artery absent end diastolic flow or reversal in the aortic notch, and biweekly 34 weeks cesarean section may be considered at 34 weeks. Low suspicion of fetal acidosis would be the stage 3, where there is absent reversal of the end diastolic flow, and ductus venosus is showing a pulsatility index of more than 95. Maybe we have monitoring for 1 to 2 days, 30 weeks, you can consider cesarean birth, and high suspicion fetal acidosis, ductus venosus reversal flow, then CTG is showing less than 3 movements, fetal heart rate decels are seen, then 12 hours maybe you can give for optimization, and if it's 26 weeks or around, then you would consider C-section. So the gestational age will determine, as well as the pathophysiological correlates and criteria will determine how you're going to manage this. So how do you diagnose a fetal growth restriction? By ultrasound biometry measurements, discrepancy between actual and expected sonographic biometric measurements for a given gestational age, HGA, which is defined as birth weight below the 10th centile corrected for gestational age. So the factors to be monitored are the growth trajectory, umbilical artery Doppler, and amniotic fluid volume. So as we understood, fetal biometry has to be taken and especially taking into account the abdominal circumference. Follow-up after diagnosis is very important, where you do serial assessments, fetal size evaluation, sequential growth assessment, and recommended interval for this is 3 weeks, as shorter intervals increase a false positive diagnosis. Now, umbilical artery Doppler in SGA, when it's diagnosed by biometry and follow-up is by Doppler studies, umbilical artery Doppler should be the primary surveillance tool, and when normal, repeat surveillance every 14 days. Are there any other methods apart from ultrasound? Maternal perceptions of fetal movements, NST, CST, and fetal BPP. Fundal height can be a very simple tool, and if there are more than 3 centimeters lag, starting at 24 weeks of gestation can be your cue to look at the growth and the Dopplers. Now, whenever we are looking at abdominal palpation, which we know has a limited accuracy for prediction, Serial measurement of SFH from 24 weeks improves prediction of an SGA neonate, better if plotted on a customized chart. If a single symphyzofundal height plots below the 10th centile or serial measurements demonstrate slow or static growth by crossing centiles, should be referred for ultrasound measurement of fetal size. And it's not useful if BMI is more than 35, large fibroids, hydramnios, or this would definitely require an ultrasound. Now, material perceptions are something which are very important, and this typically called as a kick count, 3 movements in 1 hour, 10 movements in 12 hours. Count fetal movement and note the mean time needed to count 10 moves, and should inform if it is taking longer to perceive these movements. Sometimes obese women are unable to perceive the fetal movements, and then you would have to do sonographic surveillance. So if risk factors are there, start the kick counting at 26 to 32 weeks. If low risk, then in the 3rd trimester, we usually start at 34 to 36 weeks. The advantage is it's a simple test. Disadvantage is low compliance. Only gross movements can be appreciated and cannot predict poor outcomes. Now, in Norway, a fetal movement awareness program resulted in reduction in stillbirths in women with decreased fetal movements without increasing overall presentations for DFM or inductions of labor. And that is the reason why these kick counts have come back into our practices. And the authors attributed the decrease to a reduction in delayed presentation with DFM more than 24 hours and more than 48 hours, and increased identification of fetal growth restriction via ultrasound scanning of all women with decreased fetal movements. A reactive NST rules out fetal acidemia. Non-reactive NST can be false positive and needs further evaluation. Repeated decels reflect fetal hypoxia or cord compression due to oligohydramnios, and this is associated with high perinatal mortality rate. So presence of accelerations with movements confirm reactivity of the fetus, must be done after a meal or a proper hydration. If reactive, indicates absence of fetal acidemia at that point. Computerized analysis is superior definitely and can identify hypoxia better. NST cannot predict severity of deterioration. Now, the Maternal Fetal Medicine Consult Series 52 proposes that weekly CTG testing without absent or reverse end-diastolic flow can be considered in uncomplicated cases, and frequency is increased if they are complicated by absent or reverse end-diastolic flow, other comorbidities or risk factors. Now let's look at the predictive value of this test. CST is something which we are not doing in our country so commonly. Has a high false positive rates, leads to unnecessary interventions, while NST also has high false positive rates, especially in high-risk cases like diabetes, FGR and post-dated. There is a high false negative rate, which is unacceptable. And biophysical profile, low false negative rates, less than 0.1%, means less than 1 fetal death in 1,000 within 1 week of normal BPP. So what do we look here? The fetal tone movement, respiratory movements, heart rate activity, amniotic fluid volume, and a BPS of 8 is reassuring of fetal well-being. And we are well aware of the sequence of deterioration, which will start with loss of fetal reactivity, absence of breathing, decrease in tone, decrease in fetal movements, score of 4, which is abnormal, and BPP deteriorates very late and can be very rapid. Now, amniotic fluid assessment is done by a single pocket of 1 centimeter. 4-quadrant AFV assessment, 96% of fetuses with fluid pockets less than 1 centimeter may be growth restricted, and oligohydramnios may precede lagging fetal growth. CTG, not done alone for surveillance. Please remember, if abnormal Dopplers are seen, twice weekly testing is done. If non-reactive CTG, full BPP is done. BPP is not useful as a standalone test, nor is CTG, please remember. And this may need daily CTG testing in severe SGA. So you have to use your clinical acumen to take a decision in these patients. So when we look at the SMFM guidelines, they talk of weekly NSTs after viability, increased frequency warranted based on Doppler abnormalities or other clinical indications, and it addresses BPP in the statement and finds that further studies are required to prove its usefulness. Now, what in SGA? So it's actually in SGA, diagnostic and monitoring tool comes from the fetal and the arterial venous beds, which tells us about placental bed resistance, So venous waveforms, always remember, provide information on the cardiovascular status of the fetus. So when we are looking at the sequence of progression, placental insufficiency, decreased nutrients, preferred streaming to heart compared to liver, AC decreases. So whenever there is a decrease in AC, this has to be explained to the patient. Reduction in umbilical venous flow is the first hemodynamic change, and increased resistance in the umbilical artery then occurs because of increased resistance in the placental vasculature. So when we look at the Dopplers in the umbilical artery, the resistance indices to increase is PI is more accurate. 30% of damage to the placenta is the significance and leads to decrease in the end diastolic flow. Extreme increase in resistance causes absent end diastolic flow, and reverse end diastolic flow tells us that there is 60% damage. And therefore, early response is always compensatory because I told you the babies want to live. So umbilical artery diastolic flow is still seen, decreasing middle cerebral artery impedance, decrease in the CPR ratio, early and sensitive marker of redistribution of cardiac output, precedes growth delay by 2 weeks, cardiac function is still normal, and hypoxia may be present, but yet there is no acidemia. So whenever there are brain changes, that means there is a fall in the MCA, which is brain sparing, CPR, where the umbilical artery vasoconstriction versus MCA vasodilatation. If it is less than 1.08, it is pathologic. Late FGR can have abnormal MCA flow without uterine artery changes, mandates delivery. So when we are looking at MCA, it's a cerebral Doppler, useful after 32 weeks if normal, repeat after 2 weeks if abnormal, do weekly testing. And late responses decomposition comes from, now you have an AEDF, REDF, abnormal venous flows in the precordial veins like the ductus, IVC and umbilical vein, oligohydramnios are signs of ominous outcome. Strongest predictor of stillbirth. And their ominous are absence of reversal of ductus venosus A wave and umbilical venous position, mandates increased fetal monitoring, or maybe discontinuation of that pregnancy, or maybe allowing, if the baby is too small, closer to the limits of viability, you may consider it going into an IUD, explaining, of course, to the patients. CTG should not be used as the only form, as I told you. Short-term fetal heart rate variation from computerized analysis. Amniotic fluid should also not be used only as a single thing. And it's been found that the single deepest vertical pocket is more sensitive and a better predictor. So what should be the optimal frequency of Dopplers? In normal umbilical artery Doppler, weekly testing of umbilical artery, biometry once in 3 weeks. Monitoring is done to identify fetuses that are at a higher risk of in utero demise and neonatal morbidity and may benefit from preterm births. Repeat Doppler surveillance twice weekly with presence of end diastolic velocities and sometimes even daily in the absent or reversed end diastolic frequencies. Now, in a late FGR, abnormal umbilical artery Doppler, it's always better to do a delivery. Middle cerebral artery Doppler less than the 5th centile PI has moderate predictive value for acidosis at birth and should be used to time delivery in term FGR if there is normal umbilical artery Doppler flow. And ductus venosus has moderate predictive value for acidemia and adverse outcome. So our goals of surveillance are to avoid stillbirth, iatrogenic preterm births, and if possible, avoid long-term adverse health outcomes. So one has to understand the differences between SGA, FGR, and AGA. And FGR are typically due to intrauterine malnutrition and growth compromise irrespective of the birth weight centiles. So if between 5th to the 10th centile, normal growth velocity across gestation, normal physiology, normal AFV and umbilical artery Doppler, AC growth velocity above the lowest decile has to be monitored. Now, when you have a pathologically growth-restricted fetus less than the 3rd centile, abnormal umbilical artery Doppler, you can consider using this algorithm. So first look at the growth, which is less than the 10th centile. Looking at the gestational age, you classify whether it's early or late or whether it's severe, that is less than the 3rd centile. Do a detailed ultrasound, diagnostic genetic testing if it's necessary, if it's an early onset FGR, sonographic abnormalities or polyhydramnios. PCR, CMV on amniotic fluid if patient has amniocentesis. Fetal surveillance, uterine artery Doppler, CTG. Deliver for repetitive late decelerations after fetal viability. If the normal uterine artery and everything is finds to be normal, EFI is more than the 3rd or the 9th centile, you can put through the frequency as I mentioned and deliver at 38 weeks. If it is decreased EDV, deliver at 37 weeks. If the AFW is less than the 3rd centile, then deliver at that point, even if it's around 37 weeks is better. Uterine artery absent EDV, consider inpatient admission, and then, Dopplers maybe twice or thrice in a week. CTG also done interspersed and deliver at 33 to 34 weeks. And if it's a reverse end diastolic flow, then optimize for maturity with steroids and magnesium sulfate and deliver these patients. Infections such as CMV, toxoplasmosis, rubella, and varicella can have sonographic markers such as non-specific echogenicity, calcification of brain and liver hydrops, and sometimes even malaria can be responsible for this. So when you are managing the early onset FGR, history, physical examination, soft markers, suspicion, and all these required to be looked into. And with major risk factors, as we understood, we'll be putting them through a close surveillance. And this is a similar growth chart, which is telling us about management and surveillance in SGAs. Whenever you have expected fetal weight less than the 33rd centile, normal multivessel Doppler findings is an SGA baby, keep a surveillance on them. It may turn into an FGR. Stage 1 FGR we have already studied. Stage 2 we have discussed, and stage 3 and stage 4 as well. And delivery is indicated in all cases where there is abnormal NST, oligohydramnios less than 2 centimeters AFI, presence of uncontrolled maternal hypertensive disorders, or any other maternal condition that warrants delivery. So this is a similar one. I'll just go through this, and these are certain places where you can go and read more about this. In summary, management protocol, role of aspirin, role of LMWH also have been recognized. And delivering a preterm SGA is a challenge, and we have to be delivering them correctly because you must give them antenatal steroids, magnesium sulfate for neuroprotection. And to diagnose a very late preterm, you may consider doing a sonography even at 32 weeks when you are suspecting any kind of growth problems there. Now, if you look at the antenatal surveillance protocol in the UK, you can see that they have used many biochemical markers at various point lines, while in our country, we would be able to only base more on history, more on a clinical acumen, and sometimes using these biochemical markers. And we have to have this strategy devised for each patient when you have done a historical risk assessment. So at the end, I would like to give a message. Optimum method to diagnose FGR is AC or EFW less than the 10th centile. Biometry then done every 3rd week after diagnosis. And if low growth velocity, umbilical artery Doppler should be used as a surveillance tool. And the SMF also mentions about the same things, about the normal flow velocities and the abnormal end diastolics, which we have already discussed. And remember that routine testing for fetal size and uterine artery Doppler at 34 weeks not needed in low-risk women. Uterine artery is of no use in 3rd trimester. MCA Doppler reports cannot be used to time delivery. Venous Doppler used to time delivery in early FGR. MCA Doppler used in the term FGR for timing delivery if there is normal UAD and abnormal MCA, that is PI less than the 5th centile. Short-term variability in CTG is used for surveillance, computer analysis better. AFI is best with the single deepest vertical pocket, and you cannot use BPP singularly, but you have to look at composite things. So the SMF recommends against use of routine Dopplers, and therefore we have to select them by biometry and then use it, and choose your timing of delivery wisely depending on the Doppler studies and the gestational age. And also consider cesarean section. It's no strict recommendation. That is where you have to use your acumen as a clinician and document everything that you're doing so that if there's an adverse outcome, you're able to answer the patient. So this is typically the flow chart of the timelines of an early onset fetal growth restriction and the late FGR, as you can see, by gestational age. And all these Dopplers can help us in understanding and picking up these cases. Thank you so much for giving me this opportunity.
Thank you so much, Girija Wagh, madam. That was indeed excellent and exhaustive. Can I have the chairperson's comments, please?
very nicely elaborated all the topic in very simple language, and almost all up to the delivery we can very much nicely understand this topic.
I think, Girija,
Thank you,
it's
ma'am.
always,
Thank you so much.
yes, it's always a pleasure to listen to you. Your topic, you make the topic very simple, but very practical as well. And you know, with the, it's not only the experience, it is evidence-based. So we are very happy to have you, and we're very happy to listen to you, Girija. Thank you.
Thank you so much.
Yeah. Thank you so much for everything. In fact, yes.
Now we move on to our third session, which is a panel discussion for today, for which we have a moderator, Dr. Sneha Bhuyar, Madam. She is known to everyone and she has been conducting these sessions. This is the 57th session. She has many awards and accolades to her credit, among which is National Faculty HPP Award, Master Trainer, State Coordinator, IMA Maharashtra. She has been an organizing chairperson for many conferences. She has received official posts that she has held up till now as being a chairperson of the Press Committee, FOXY 2019-2021, Governing Council member, chairperson, Medical Disorder Committee, founder, president of Vidarbha ISOPAP, president YOGS,
Yes.
clinical
Thank you.
secretary.
Thank you,
Okay.
Pratibha. That should be enough. Yes. Thank you.
Okay. I invite the two experts for today, Dr. Prashant Purandare, sir. He's a renowned experienced obstetrician gynecologist who's completed his graduation, post-graduation OBGY from BJ Medical College. And he is a past president of Nashik OBGY Society, trustee NOGS, secretary state AMOGS. He has given many TV programs and received many awards in his career. I welcome you, Dr. Prashant Purandare, sir. Next slide, please. And another expert for today is Dr. Kiran Patole, sir, who is a professor and HOD of PG EMI Nashik and Deputy Dean. I welcome you, Dr. Kiran Patole, sir. And I'll introduce the panelists as well. Dr. Vishal Patil, sir, who has done his... Okay, hello, Dr. Vishal Patil. Hello. He has done his MBBS, DNB, and is a senior registrar at Galaxy Hospital. Okay. Welcome you, Dr. Vishal. Okay, next slide. Dr. Sachin Khedkar, he's done his MBBS and MS from GMC Nagpur. He's a consultant gynecologist and laparoscopic surgeon at Khedkar Hospital and secretary of Chalisgaon OBGYN Society. Next slide. Dr. Anand Patil, who's the secretary of Malegaon OBGYN Society. Dr. Aradhana Bhamre, madam, who's done his MRCOG, MS, FMS, diploma in gynec endoscopy, consultant at Ram Hospital, Dhule, University Gold Medalist in MS OBGYN, ex-professor D.Y. Patil Hospital, and conducted several cervical screening camps. And she's a trained colposcopist, FMF certified sonologist. I welcome you, Dr. Aradhane. We have Dr. Vaishali Patil, who is a DGO and finished a DGO from Pune. She's an active member of FOXY and IMA. And I welcome you, Dr. Vaishali Patil. Dr. Sumit Sashikala Vavhal. She is a junior consultant at Sushmit Nursing Home, Malegaon. She has finished a UG and PG from St. GS Medical College.
Dr. Sumit Shashikan Vavan. Welcome.
Okay.
Yeah.
Welcome you, Dr.
Thank you
Sumit.
so much.
Yes. Thank you. You can start with the
We
panel.
have Dr. Mukund Karambirkar, a very senior obstetrician from Chalisgaon. Yes. So we also welcome you, sir.
Thank you, madam.
Yeah. We know, sir, since many years, and of course, we are eager to have your inputs as well. So I welcome all the experts, Dr. Prashant Purandare, Dr. Kiran Patule. I think if you can stop sharing, Pratibha. Stop sharing. Yeah, I'll do that. So without much ado, we would like to go ahead with our panel discussion, and I would like to welcome the experts for today's program, Dr. Prashant Purandare and Dr. Kiran Patule. I will also welcome all the panelists already, Dr. Vishal Patil, Dr. Sachin Khedkar, Dr. Anand Patil, Dr. Aradhana Bhamre, Dr. Sumit Vaval, and of course, Dr. Mukund Karambirkar, sir. So friends, our topic for discussion today is near miss case scenario. And I'm sure this is the best picture you can, which can explain the gravity of the situation and the urgency of intervention that it demands. So friends, near miss is a terminology which we have borrowed from the airlines industry. And, it is defined as the critically ill woman, pregnant woman, or a recently delivered woman who would have otherwise died had it not been the luck or good care on her side. So analyzing such cases, going through the discussion will definitely help us to improve the quality of care, and also it will, point towards the quality of service and point of areas of improvement, I would say. So according to WHO, almost 8.23% of such cases, that is near miss, or what is also called as severe acute maternal morbidity, they are preventable maternal deaths. Okay, so we have to really introspect. And when we are talking about maternal mortality rates, it's not only numbers and rates and ratios. These are women, friends. So we obstetricians have seen their faces in the faces of their agony, distress, and despair. And these faces keep on haunting our dreams. That is how it has been expressed by Dr. Mohammad Fatala, who is the past president of FIGO. And similarly, Ian Donald has also expressed that looking back over the clinical times, one tends to, take it for granted the success. But these are the failures which stand out like keloids, reminding the person who has faced it, and of course, hopefully the warning for others. So I'm sure all of you agree to me that because of the changing demography, more and more of these medical as well as surgical emergencies we are facing because of the associated comorbidities. So the women are becoming more and more of career minded, their academic stress, and also their unhealthy living habits, the eating habits, lack of time for exercise leading to obesity, smoking, drinking, all this, substance abuse will add fuel to the fire. Obesity leading to infertility, ART procedures, and the associated complications, definitely the rising incidence of cesarean section and the complications which follow all this. So every case is a new challenge for us. So friends, never stop learning, because life never stops teaching us. So life is the best teacher. So are we good disciple? So let us all learn together. So Dr. Vishal, we start from you. Dr. Vishal?
Yes, madam. Okay.
Yes. So we start the warming up case from you. We have this second gravida who is undergone cesarean section 1.5 years back. She comes to you with 7 days overdue. Urine pregnancy test is positive, and she asks you for the medical termination pills. So, the doctor prescribes her MTP pills and calls her for follow-up after 7 days. But, suddenly on day 5, the relatives bring her in a collapse condition. When you examine, you ask the history, she gives you a history of only spotting and giddiness. There's no external bleeding. When you examine, she's got tachycardia, pulse rate 132 BP, only 70 millimeter of mercury, systolic, and pallor plus. So what is your differential diagnosis at this point of time? How will you investigate and manage this patient?
Madam, as a patient is second gravida, already UPT positive, it's a clear case of ectopic pregnancy, and patient is BP is falling, patient is collapse at home. So it must be rupture ectopic. But
whether it is ruptured tubal or ruptured scar ectopic, because she's
that's why I'm coming to the second point is that I wanted to investigate whether it is ruptured tubal ectopic or scar ectopic. So that can be only confirmed by laparoscopy or laparotomy. Either way, whatever is the operative is decision is there. USG is already done, which shows adenoaxial mass along with free fluid. So adenoaxial mass may be suggestive of it's a tubal rupture ectopic pregnancy. So less likely it will be the scar ectopic, rupture scar ectopic. HB is 7 grams. So I think it need to be shifted to OT emergency along with proper written informed consent, blood arranged, and all things are ready. And treatment will be if tube is very much torn and it's unrepairable.
So let me
then-
come to you that whether, it's an emergency, the patient is collapsed, you arrange for everything, the operative preparation, you resuscitate her with IV fluids and you ask for blood and blood products, whatever.
Yeah.
So whether you want to take this patient for laparotomy or laparoscopy, what do you prefer and how do you go ahead?
As a recent era of laparoscopy, it depends upon the expertise of the surgeon. If he is comfortable with the laparoscopy, then laparoscopy will be the best option.
Perfect.
But if hemodynamically patient is not stable and anesthetics and all the events consultants are demanding, then laparotomy can also be proceed. Whatever is that, you have to hurry up and just catch hold of all the bleeder that only survive the patient.
Perfect. So whether you would like to conserve this tube because she's only para 1?
Yes. Yes, madam. If I will definitely try to conserve.
This tube, ruptured ectopic.
If ruptured tube, madam, it's many of the time what happens, the products of conceptions are expelled from the ends.
Yeah. So, but that is tubal abortion. That is tubal abortion. Now
What
that
is
the patient is collapsed, there is possibility that most probably it is a ruptured tubal ectopic. And if the tube is damaged extensively, you have to remove this tube. Maybe I would say in the other words, I would just say that, the very fact that it has led to ectopic pregnancy, the tube has some damage, may not be physically, but functionally as well. So preferably you go ahead with salpingectomy because if the other tube may be normal, that also you have to say.
And one issue is there, so.
Yes, yes. So what I'm trying to ask you is, what is your message? What is the learning lesson from this case? Whether we could have prevented this catastrophe that has happened.
Madam, as a patient has given medical MTP pills are there, medical abortion is advised. So preferably, I think USG must be done in each and everywhere, even if it's not recommended, it's not compulsory, but it is recommended. You should always go with obstetric USG, confirm the site and all the things, and then only give MTP pills.
Yes.
That is only the bottom line message.
Yeah, and also the counseling has to be in such a way that any point of time she feels excessive giddiness, maybe fainting attacks, that she has to report any amount of bleeding. Now here you expect the visible external bleeding, but if she has only spotting and then because spotting and giddiness, then of course you have to keep the index of suspicion very high. Okay,
yeah.
That is the message to be given from this case. So thank you, Dr. Vishal. Now
thank you.
Go ahead with the second case.
Madam, I'd like to add one point.
Please.
Yeah, of course, these days blood and blood products are available.
Yes,
but in our olden days, once I had given auto transfusion.
Yes,
perfect. So perfect. That also one can keep in mind. That can be done to save the life.
Yes, we too agree with you. Even we have done that, but then that is in institutions. And nowadays you have the blood and blood products ample available. So I think maybe this generation has not seen it, but transfusion definitely. Thank you, sir. Thank you. So we move ahead with the second case, which will be very interesting. And of course, I will invite the expert also for discussion with this. So we have this 36-year-old woman, she conceived with IUR. So she stays in a village, but the husband is working in Dubai. So because it's a precious pregnancy, she comes to the obstetrician very regularly up to 24 weeks. Seeing that, all investigations are normal, she's lost to follow-up. She goes and stays in the village. So one day at around 34 weeks, suddenly she reports to the primary healthcare center with severe edema, pain in abdomen. And, when they examined, the BP was very high, 176 by 116. Urine proteins were present. So her BP was measured at PHC, that was high. So the medical officer gave her only tablet nifedipine retard and told her that she needs admission to higher center. Unfortunately, she did not get admitted that day. 2 days later, she got admitted at the higher center, that is sub-district hospital. So here they just added tablet labetalol. Now, because they had anesthetist and the OT facilities, they went ahead with the cesarean section. 1.8 kg live female baby was delivered. the BP, in spite of all this, was between 140 to 180 systolic, 100 to 110 diastolic. So the patient was on tablet nifedipine and tablet labetalol, and magnesium sulfate was continued for 24 hours. So Dr. Sachin, this patient suddenly started becoming very breathless, restless after 10 hours of cesarean section, and pulse rate was 115, BP was 220 by 118. Oxygen saturation dropped down to 70%. Her chest was full of wheeze, no clear breath sounds. So what is your differential diagnosis? Do we have Dr. Sachin? No, I can't see Dr. Sachin. I think any of the panelists. Yes, Dr. Aradhana, you want to take up this case?
Sure, ma'am.
Yeah, please.
Any severe preeclampsia patient post-ops complaining of severe cough, breathlessness, and restlessness. The first differential diagnosis has to be a pulmonary edema.
Perfect.
Other differentials could be probably some new respiratory infection which has come up. And yes, we'll carry out our investigations in order to rule it.
In addition to pulmonary edema, whether you would like to keep your differential diagnosis, anything else?
There is
pulmonary embolism.
Pulmonary embolism should, because of yes, dyspnea and breathlessness, pulmonary embolism should.
Any other differential you want to have? Anybody can add from the panel, I think.
Respiratory.
Catastrophic presentation, immediate post-op, I think PPC.
Amniotic fluid embolisms can also sometimes present like this.
Okay.
The
Cardiac
is
yeah, so pulmonary embolism and amniotic fluid embolism, they will progress very fast. Okay. So this patient definitely pulmonary edema or pulmonary embolism. Now, how would you manage this patient? You can continue, Dr. Aradhana.
Okay. Any acute emergency, make sure that you have a multidisciplinary team available. You have adequate help available.
Yeah. But so, let me clarify here. The patient is at sub-district hospital, right? So we have to manage this patient then and there only. You cannot shift her anywhere in this situation, right? 70%. Okay.
So principles of resuscitation: A, B, C, airway, breathing, circulation. So you immediately start oxygen. You give her a propped up position because she was, she's having, if your differential diagnosis is pulmonary edema, we need to clear out that fluid from the lungs.
Right.
So injection Lasix will help.
Yes.
Even if it's a sub-district hospital, if the anesthetist is available, then we can take their assistance and make sure that the airway is secure, at least oxygen by mask. And then we'll take it further how the patient is responding to the initial resuscitation measure.
Yeah, but her BP was 220 by 118.
He was, yes, because severe hypertension and oral antihypertensives are not helping. So injection labetalol will help in this case.
Okay. So
get the blood pressure.
Yes. So given a choice, nitroglycerin infusion should be the drug of choice for this patient. But yes, labetalol was available, so they gave labetalol. So as per your management, yes, they gave her propped up position, oxygenation, and labetalol and Lasix IV 40 milligram. Everything by the time, because it was a catastrophe, within few minutes, the patients become pulseless. BP was not recordable. Oxygen saturation further dropped to 55%. Now, on umbo-assisted respiration, as you said, the anesthetist, carried her to ICU. But before that, she went into cardiac arrest. Now, how do you manage cardiac arrest?
So cardiac arrest, again, we need to... so now, ma'am, do we have a team available with us or no? The anesthetist or some physician?
Anesthetist, yes. See, I've said that anesthetist helped her to shift to the ICU. So naturally, they are there.
Right. So for cardiac arrest, the anesthetist and the physician actually have to take over.
Yes.
So the
CPR.
So advanced CPR has to be commenced.
Okay. So suppose our it happens in our suppose Suppose you want to do it, you have to do it yourself. You have anesthetists here, but suppose just we want to inform our attendees so that, you know, even if it can happen in any of the hospitals, maybe in the ward itself all of a sudden. So how do you carry out the cardiopulmonary resuscitation? How many compresses you give? How do you give the breaths, and how do you manage?
So one person takes care of the cardiac compression, and if you have another helper, then that person can take care of the respiratory
Breathing
support.
part, yes.
In the hospital, we will always we can have an AMBU bag, so that AMBU bag can help in the respiratory support. So as far as I remember, after every 4 cardiac compressions, which are given in quick succession, 2 AMBU respirations should be given.
4:1 should be good enough. But how many compresses you give, and how do you give the compresses?
So the compression are given with the palm of the hand, which are clasped together, and the elbows the elbows are straight, and maximum pressure at the xiphisternum. And
Lower part of the xiphisternum.
Lower part of the xiphisternum.
So initial thrust, one thrust, and then you give CPR. How many compresses? At least 100 per minute. That fast it should be. And how much should be the chest wall compressed? Dr. Vishal, you want to, anybody from the panel is welcome to add.
2 inches. At least minimum 2 inches.
Yes, 5 centimeter or 2 inches. For with every compression, the chest should get depressed by 5 centimeter and regain itself. So that is how this purposefully, Dr. Aradhana, through you, we want to address the attendees, because this is a basic life support, and all of us, even the non-medicals are supposed to know this. So that's the reason and thank you so much. You expressed it very well. So now this CPR was given, and within few minutes and 1 hour, she regained her consciousness, regained her blood pressure, spontaneous respiration, everything. Now I would ask, I think, do we have Dr. Anand Patil here? Right from the beginning, how this patient was mismanaged, what went wrong and where? All of you can take up one point, then we go serially. And then we ask Dr. Prashant Purandare to, analyze and give his expert comments.
Madam, as patient is already case of PIH, BP is 176, 116, 2-week proteinuria plus, patient need to be admitted on the same day.
Yes.
But patient went home and came after 1.5.
I will just interrupt you here, Vishal. I want you to go little earlier, right from the first history of, 36-year-old lady. She conceives with IUI. Yeah. So any risk factors here? You have some prediction for HDP justosis score right from the beginning, whether you should have added some medicine earlier in the first trimester itself.
Yeah, old age patient. It's the age is 36, IUI, so precious pregnancy. So would have been better. In early pregnancy, ecosprin must be started.
Yes, so basically it is elderly primary gravida or elderly gravida for that matter. So that itself scores her at a higher score, right? So she is a high risk woman. So early pregnancy scanning, even at 11 to 13 weeks, when you do the scan, you just now heard the FGR talk, right, by Dr. Girija. So NT scan, when you do, you try an artery pulsatility index. And then, of course, where you have the facilities, PLGF and SFLT. So all these screening procedures should have been done for this patient, right? We are routinely doing HDP justosis score by maternal characteristics. Okay, so this is one point. And then I think we can have Dr. Prashant Purandare's opinion. Yeah, Dr. Prashant. Yes, please.
This is a typical case of what we are, the topic of today's is near miss.
Yes.
And we should have definitely considered 3 things in this: risk factors, remedial factors, and avoidable factors.
Right.
Her age, IUI pregnancy was definitely a risk factor.
Right.
Remedial factors, definitely she should have not gone to the rural place. Definitely she should have been monitored properly in the antenatal care, and definitely she should have been shifted to the tertiary care.
Perfect.
And avoidable factors. Avoidable factors is shifting her immediately. And the Maxel should have been given at the first step only.
Yes.
Probably could have saved her so much things in life. And this is a classical near miss, but luckily she survived.
Yes, so that is what it is, you know. So as an obstetrician, managing obstetrician, what he has pointed out, prediction. So right from early pregnancy, simple maternal characteristics can give you so much of information. And then of course, low dose aspirin and high dose calcium should have been the preventing measures for this patient. When the patient, you know, comes to you regularly up to 24 weeks, what more do you want? We as obstetrician, we should take the responsibility of saying that you are a high risk woman. You need to come for regular checkup. And in fact, at every visit, we need to reassess her and rescore you. If at all you go as a high risk, even still further, we may have to, you know, start you on some medications. So if now that she goes to the PHC with so much of high BP, there they can't give IV labetalol, agreed. But, you know, Government of India guidelines, if you see, they can definitely give the first dose of magnesium sulfate, that is one. Secondly, they can definitely give the 10 mg capsule nifedipine, which is so simple, orally, not sublingually, right? So sublingual capsule nifedipine, I'm sure those who are from BJ or maybe even other institutions, in 3 decades ago, labetalol IV was not available when we were the PG students, and even today we are very comfortable using capsule nifedipine orally. Okay, so 10 milligram capsule nifedipine orally gives you fantastic results, very good optimization of the blood pressure. So that should have been given even at that point of time. And then of course you have, you know, sub-district hospital just having OT and having anesthetist should not accept such patients and should not operate. And such patients needs obstetric HDU or ICU care, and they should be transported to the higher center, tertiary care center. So that is what is the message we have to learn from this case, right? So we go ahead with the next case now.
Madam, can I add one case only here?
Yes, please.
Madam, just in last month maternal mortality review meeting, we had one case of remote places in Dhule district only. The patient is family patient, done cesarean section at Taluka place. Patient discharged on after stitch removal. Day 15, patient complaints of chest pain and breathlessness. Patient came to the hospital with saturation 80, 85, with BP 200 by 120. That consultant just give the physician call, done ECG. ECG shows bradycardia and changes. So he referred patient to the GMC Dhule. On the way, near almost 10 kilometers away from the Dhule, patient has arrest and patient did not survive. After that, PM is done. PM shows patient has cardiac tamp node along with effusion, pericardial effusion is there, and all the things. So it's just like at the time when patient visit that consultant at Taluka place, so with BP 220 by 120, he would rather have given nifedipine, Maxel, all that prophylactic things. If I had done, then we can save that mother.
Definitely.
So
You will read the last message when we come to the end, you know, because we have to manage these patients then and there only. That is what the message is. And we go ahead with the next case now. This is again for Dr. Aradhana. I hope you are okay with it, Dr. Aradhana. Yeah. So we have this 20-year-old girl, 20-year-old, primary gravida, a woman now, 9 months, amenorrhea. She came to you. You know, she was referred from some nearby nursing home where she was in labor for almost 8 hours with strong labor pains and, you know, even 3 to 4 hours prior to admission. So almost 12 hours of labor pains, strong labor pains, but there was no progress. So they decided to take her for cesarean section. So sister, as usual, tried to catheterize her, no urine. On further inquiry, they found that, you know, over last 12 hours, she has not passed urine. So now they got scared and shifted her to tertiary care center. So where the blood pressure was 110 by 70, pulse rate was 110, uterine contractions very severe, no relaxation in between. Fetal heart was only 100. And sorry for this dilatation, it is cervix 3 centimeter dilated membrane substance, and there was brownish, dark color bleeding, blood was coming out. So clinically, what will be your diagnosis? Here it is displayed. I will give you the diagnosis. It is abruptio placentae. When we did her investigations, the hemoglobin was only 8, platelets 1 lakh, PT-INR was 2, and APTT was prolonged. FTP was present. Fibrinogen was only 150 milligram percent. So what is your complete diagnosis now for this patient, and how will you manage her?
So this patient has abruption, obstructed labor, along with consumptive coagulopathy because the fibrogen has come down, FDP is present, APDT is prolonged.
And got anuria.
Stress and anuria, that's a complication with anuria. Yes.
Yes. Now how will you manage this patient?
Again, so
I ask you direct leading question. She's got fetal distress, she's got obstructed labor, she's not going to progress. Dilatation is also not favorable. Otherwise, actually, when you have abruption, the myometrium is so irritated that the patient progresses very fast. But this patient did not progress. So whether you will take her for cesarean section immediately to save the baby, or whether you will wait for some time for arrangement. How will you go ahead?
In this situation, because there is also fetal distress, we will have to take the patient up for cesarean section, but make sure that we have adequate team ready. We have assistants, OT assistants, porters, all the blood components in place. The investigations are already, she's already in consumptive coagulopathy. So we have to resuscitate the patient and then make sure that she has, we have good IV access. We have started IV fluids till the time the blood comes. And since we already know fibrinogen levels are low, FDP is present, we look if there's cryoprecipitate available, FFP available. But in the meantime, with just crystalloids infusion, go ahead.
Let me just interrupt you here. But then the patient has come to you with fetal distress.
Yes.
Right? So by the time you make arrangements for blood and blood products, it will be too late.
No, we cannot wait for blood to arrive. In the meanwhile, we have to start with IV fluids. Bring the solution.
So everything together simultaneously, right? As you said, what we label it as aggressive fluid resuscitation. Because why she has suffered oliguria? Because of the hypovolemia. And this BP of 110/70 is very deceiving. She may be hypertensive and she has had abruptio. After that, she is now into hypertension, right? So aggressive fluid resuscitation, arrangement of everything, take her out for cesarean section. It is not even a very established DIC. If you can see here, platelets 1 lakh, and the APTT is prolonged, but fibrinogen still 150. So with all the arrangement ready, you can go ahead with the cesarean section. Now, what precautions do you take during cesarean section?
During cesarean section, at the start, we inform the anesthetist. They can start injection tranexamic acid. We have to proceed as fast as possible. We have to be prepared for atonic PPH. You have to deliver the baby as fast as possible. The placenta could be adherent. It could be morbidly adherent placenta. We'll be prepared for that.
I would add to this. It's not only atonic, APH followed by PPH. So here it will be atony as well as the coagulopathy, right? She's in DIC already. So even that will add fuel to the fire. So you have to be ready with the PPH management. So naturally, you prefer which oxytocic you will prefer for this patient? Utrotonic, which one you will prefer?
Ma'am, because
yes, Vishal.
Hello.
Hello. Yes. Go ahead. Hello.
Yes, madam. 20-unit oxytocin
must
be started after the delivery of baby. Along with that, I will be preferring prostrodin, even if carbodicin is there, but I will like to use prostrodin, carbidocin, rather than carbidocin.
That is what I'm trying to say, that carbitocin is the best agent available, oxytocic, at present. Because, it is almost 16 times more potent than oxytocin, that is one. And oxytocin, once you give, in large amount or concentrated infusion, if you use oxytocin, carbitocin doesn't work later on because it will have the same receptors. Okay, so prophylaxis with carbetocin, and then maybe you continue with oxytocin, or as Dr. Vishal said, if you still have a intention, if you still have a fear that she will bleed, then you can go ahead with carboprost, definitely. Okay, so naturally you have to manage this aspect also. For coagulopathy, now you tell me which blood component do you require for this patient?
Whole blood, FFP.
Yes, fibrinogen. So for fibrinogen, whether you prefer FFP or you prefer cryo?
Cryoprecipitate
Given choice, yes, yes. Given a choice, you should prefer cryoprecipitate because FFP, fresh frozen plasma, has its own disadvantages. I think we will listen from our expert, Dr. Prashant.
Madam, I call it as an acute transfusion ATP. So you
Yes.
should give all the platelets more fibrinogen, and it should be the fibrinogen level more than 150 milligram per DL. Hematocrit should be more than 25, and platelets over 60,000. Once you achieve this, you have almost
Our patient has platelets of 1 lakh, so we are not worried about platelets, right? So it's only the fibrinogen which is worrisome for us. So how do you, whether you prefer FFP or cryo?
I'll go for FFP.
Okay. Anybody else to differ?
What is easily
Yes.
available is preferable.
Yes, naturally, whatever is available at your place and at your setup, and whatever you have used in the past, which you are comfortable with, that's the best answer. But given a choice, cryoprecipitate is the best. Because, you know, FFP is fresh frozen plasma ultimately. So whatever disadvantages you have with plasma, that is TACO and trolley, the transfusion complications, they are more with FFP, right? So cryoprecipitate should be the one which should be preferred. So thank you, Dr. Vishal and Dr. Aradhana for that wonderful discussion. And we have Dr. Vaishali now for the third case. Dr. Vaishali?
Yes, madam.
Yeah, so here we have this 32-year-old para one with previous 1 cesarean section, male child 1-year-old. Now she is 6 months pregnant. She was registered at some other city because of her husband's transfer, job transfer. She comes to your city, and all of a sudden she, experiences spotting per vagina. So she reports to you. You examine her. Ultrasound is done. You find that the placenta is low lying. There is absent RP leg, 26 weeks fetus, otherwise normal. Anomaly scan is also normal. This lady comes back to you at 30 weeks again, and she starts bleeding because she starts bleeding profusely at home. While doing the investigation, she collapses in the hospital. So what is your diagnosis and how will you manage this patient? This emergency we talk about first.
Yes, ma'am, because she is G2P1 with previous LSCS and ultrasound shows placenta previa. So she is a case of placenta previa, and now she has collapsed. And because of a previous section.
One more point I tell you, absent RP leg.
Okay.
So that is placenta previa.
Accreta. Yes, morbidly adherent placenta she might be having.
Right.
Yes.
So how will you manage this patient?
This is an obstetric emergency because she has come with hemorrhagic shock. So we have to hurry, like we have to resuscitate her first, arrange for blood, start blood transfusion. And because she is preterm, she's just 30 weeks. So the prognosis, the baby is too much preterm, but then we have to deliver her immediately. Right. We have to go for cesarean section.
Okay. Cesarean section.
Yes.
Okay. So you do cesarean section, remove the baby. Then what happens to the placenta?
Yes, we have to take a consent for obstetric hysterectomy as well. We have to take informed consent because yes.
While discussing with the patient and relatives or the family, you have to discuss that this is an emergency, dire emergency, and we have to save the mother. So we need to prepare up for emergency operative procedure, which will not be only cesarean section, but it will be obstetric hysterectomy. And then you have to counsel regarding the prognosis of the baby, that it's only 30 weeks.
30
So
weeks,
we
yes.
cannot assure you about the survival of the baby in spite of the best of the NICU care. Okay,
Yes.
so make sure that you transfer the baby to the best NICU, but still you have to take everything in writing. So informed written consent. So what consent you take? That is what I'm asking. Caesar, yes. Obstetric hysterectomy, yes. And the baby's outcome, yes. What else? High risk,
Consent.
yes. The patient, it's very simple. You have
Other than obstetric
only,
hysterectomy?
yes.
Okay.
The patient will lead large amount of blood and blood components, massive transfusion protocol may be initiated, and because of all this, the patient may become moribund. You may even lose that.
Postpartum sepsis, DIC, that also the procedure related complications also we have to take the consent.
Perfect. Now, before you take this patient, now you start all the arrangement. You have made the OT, blood bank, everything, all your team. So who all do you want in your team? Apart from obstetrician, anesthetic,
Neonatologist and
who all do you want in your team?
Pediatrician, neonatologist.
That is the routine procedure.
Yeah,
Who else?
physician maybe because of the if she might require more blood transfusion, so physician or intensivist.
Okay.
Like this is the case for tertiary care center.
Yes.
When she's in a hemorrhagic shock.
Yes. Anything else? Anybody
And
else?
senior anesthetist, senior obstetrician.
Okay. Anybody wants to add anything to this? Yes, Dr. Vishal, Dr. Anuradha.
Of the tertiary care hospitals, transfusion specialists are also available. So if they are there and enlisting their help.
Maybe urologist, madam, if the placenta percreta is there, then if there's bladder invasion, then you might need to see bladder, ureters.
Also intervention radiologist, preoperative embolization of the internal iliac arteries.
That is what. So all in all, we have completed the team as we, interventional radiologists, preferably you can go ahead with the embolization, or nowadays even the aortic balloon, So all these pre-operatively if done, maybe they reduce the hemorrhage during the operative procedure. So definitely it's even if it is not only percreta and if it is accreta or increta, it's better that you always have either a neurosurgeon, preferably a oncosurgeon, or even a simple general surgeon if it is, if he is not available. Okay. So if given a choice, and if you have available oncosurgeon or neurosurgeon, but general surgeon also should be okay. Anything else, Dr. Karambulkar sir? Sumit Babu?
I will myself for baby neuroprotection.
Here there is no scope, Dr. Vishal. Otherwise, you are right, because the patient has collapsed. We don't have to bother about the baby. In fact, we have to hurry up and take the patient for LSS at the earliest. So if you give magnesium sulfate, in fact, the anesthesia and other things you may have to wait. So here we don't have much time, and we don't have to think also for the baby, whatever. Now we come to it when what went wrong. I will definitely ask you, okay, whether we could have prevented this. Okay, so this patient, now you have the whole team ready. Now you tell me, how do you go ahead with the operative procedure? What precautions you take during the surgery? Which incision for the skin, which incision for the uterus? Vertical or transverse?
Vertical incision would be preferable.
Yeah.
And classical incision over the uterus, so that we can bypass the placenta and deliver baby.
Yeah.
And if needed in situ placenta, we should not disturb, and we can do hysterectomy.
Perfect. So I think even post-operatively, you have to monitor this patient in ICU. You have to take care of for at least 72 hours, because transfusion-related complications, even the other coagulopathies, all this you have to keep it in mind. So that is how we manage this case. Now we retrospect ourselves. Dr. Sumedh, I would ask you, was this catastrophe preventable?
Ma'am, as like she presented with placenta previa, and it was already a diagnosed case of placenta previa. with she having a previous history of cesarean section. So on USG it was also placenta accreta. So instead of sending
That
her
was
home,
at 26 weeks when she started, when she had multiple bleeding episodes. But suppose in the early pregnancy, maybe 11 to 13 weeks, you find that everything is fine. Maybe little later, 18 weeks. Now we come to the recommendations also. So suppose at 16 to 18 weeks, you find that everything is normal, no anomalies. Whether you should go for osteotomy for such patient.
ma'am, no, there is no indication for
No.
osteotomy in this patient.
Strict no to osteotomy. That is what is the message. In fact, it will be harmful if at all you prick the placenta. Okay.
Yes.
So absolutely no. Osteotomy only for short cervical length of less than 2.5 centimeter, not for placenta previa. Okay. Any role of tocolysis? You want to?
Ma'am, in this case, there is no role of tocolysis as already the patient is in a critical condition. So
Yes,
giving
and
her
there
a
are no
tocolysis,
contractions. There were no contractions.
yeah, there were no contractions also.
Yeah. Okay. So, now this patient, when she came to the obstetrician during 6 months, she was diagnosed with, she was having bleeding. She was diagnosed with placenta previa accreta. So, what precautions should have been advised to this lady?
Ma'am, the patient should have been advised reduced physical activity.
Should have been admitted, hospitalized.
At 26 weeks, ma'am, if she is complaining with if she has come with a complaints of bleeding PV, she should be admitted and hospitalized at that time. And later on also she had she was like later on also discharged. She should have informed that if she has any one episode of spotting PV or bleeding PV, she should immediately report to the hospital. The patient had multiple episodes of bleeding PV, and later on at 30 weeks she came to us. So it was a improper counseling on the part of the doctor, which should have been done in a good manner.
Yeah, but then when you send this patient home, was it not a risk for her that if she sent her home and she bleeds at home?
That is also that is one of the risk factor, ma'am. But on the other hand,
Suppose you hospitalize her, you reserve blood for her, but then she bleeds suddenly. Then the doctor and the relatives will say that the patient is hospitalized. Then why is she bleeding? So we have to explain everything to. Informed written consent. What will be the informed written consent when you hospitalize such patients before?
Ma'am, we like in the informed consent, we have to say that this condition, we are admitting her for observation purposes, and it is not, we are not treating the condition. The condition itself is there, and the placenta
can bleed anytime.
It can bleed anytime.
Even when she is sleeping.
Yes.
So, but then you give her pelvic rest, right? You give her not strict bed rest, but give her pelvic rest. And anytime she bleeds, we have the blood reserve so that we can immediately start with transfusion and go ahead for any procedure. So that we don't risk her life. That is what we can explain her, right?
Sure.
So the RCOG Green Top guidelines saying that after 16 weeks of pregnancy, if the placenta lies within 2 centimeters of the internal os, we have to label it as low-lying placenta, and if it actually overlies, then we have to label it as placenta previa. And mid-trimester anomalies can, whenever we are doing, it's not only the localization of placenta, but we have to see the retroplacental sonolucent zone, whether present or absent, and we have to label this patient. Once you confirm the diagnosis, you have to give them option for, hospitalization or monitored domiciliary management. So that is what, there is absolutely no role for prophylactic osteotomy and tocolysis, as we have already talked about. Okay, so once you label this patient as placenta previa accreta, we have to, our aim should be only to take her further, maybe up to 34 weeks. And then, of course, meanwhile, now comes your role, Dr. Vishal. What all things you should give for conservative management and prepare the baby?
Yeah. Role of MAXF is good, madam, because for neuroprotection, IV MAXF program is to be given. And it gives good result because I personally use it for few cases.
Yeah. So 4 gram as loading dose, as you give it in the case of eclampsia, and then 1 gram per hour, the 24-hour infusion that is to be given. And steroids, which steroids, how much?
Betinazole 6 mg, 4 doses, or dexamethasone, either way.
2 doses.
So in fact, whether I think IAP and Foxy has come up with a joint statement saying that any steroid, for that matter, whether betnesol or dexamethasone, 24 milligram over 24 hours. So whether it is 6 milligram 6 hourly or 12 milligram 12 hourly, makes no difference. They both the steroids and the regime gives you, comparable results as far as the fetal lung maturity is concerned. Okay, so that is how we have to prepare. And then, of course, we have already talked about Karambikar sir.
Yes, madam.
Mukund sir.
Huh.
Yes. So actually, we have already discussed this, but any special points from your side, what precautions we have to take for the surgery, intra-op, post-op?
I think one thing, while during delivery as well as second trimester abortion, if we suspect placenta accreta, we should not pull it. Means we have to wait whether it separates easily or not.
Right.
Secondly, that this thing, neta-butch layer, fibrosis, fibrous layer is there, which helps in separating this thing.
Yeah,
So
the
that
plane
we
of
should
cleavage.
see. That we have to see whether it is there or not on USG, and
Yeah.
then only you should this thing. Secondly, you should not push from above, so that because of accreta, it can lead to inversion of uterus as well. So that pull, push, and all those things to be avoided. And
Right.
if you know that it is this thing, it is obviously placenta accreta or percreta, we have to go for directly hysterectomy instead of this thing. When I was working in Nanavati Hospital, our Sankri madam had done once like this. She waited for 15-20 minutes and it was not getting separated naturally. Then he did it. Then she had doubts whether it is there or not. So we sent it for histopathology and it was placenta accreta. So high degree of suspicion one should have in mind whether the patient placenta is not separating easily. Secondly, Carbitech and all that, if you just like trying up MRP is not to be done in such cases. Or if you go for that, then again, retraction of uterus, how much it will be and all that, and bleeding, don't know.
Yes.
So it is better to do hysterectomy earlier than doing it
Right.
after.
That is a very, very good message, that if you are sure about the diagnosis, that it is accreta and if it is bleeding, better to go ahead with the hysterectomy earlier rather than making the patient moribund and then taking if you remember, maybe 30-35 years ago, people used to keep the placenta inside, and even we have managed many cases. Why we are discussing this, that we have managed many cases, but once in a while it can happen that the placenta becomes necrosed and it becomes so septic that the patient goes into septicemic shock, and maybe sometimes even she can bleed torrentially with secondary PPH. So in such situation you may lose the patient. So best way is to explain properly and with informed written consent go ahead with the obstetric hysterectomy.
Especially primary patients, it becomes difficult. But
Yes.
now the chances of placenta accreta is more because of certain procedures, previous cesarean, previous scars, previous pyomectomy and all that. In those cases, means we have to suspect this high risk patients.
Right. So, thank you, sir. Thank you so much. So this is actually a chart which is showing you the volume of FFP, Paxil, platelets and cryoprecipitate and how much it contains. So here you can see if you have a patient of severe hypertension, who is usually in fluid overload and can go into pulmonary edema. So if you have less of fibrinogen, you have to prefer cryoprecipitate because the volume is only 5 to 20 ml and it has got factor 7C, 1 millibrands and fibrinogen almost 10 milligram % in a unit. So that is why you have to prefer cryoprecipitate. Any comment on this from the expert? I think I don't see Dr. Kiran Pathore joining. Is sir there? No. So should we continue or we wait here and conclude the panel?
Conclude.
Yes. Yeah, that is what. So I would just conclude this panel and just give only this, from this case, I want to give you one message. This was a case actually where multi-gravida, where large size baby, she, reports with obstructed labor. The cesarean section is done without any complication, little tear. But this patient, being everything well intra post-op, when goes into unexplained shock. So that is non-hemorrhagic shock. When you do her bedside investigation, her sugar comes very high and urine sugar 3+ and urine ketones 2+. So this lady is actually presenting with diabetic ketoacidosis. So we could have, avoided this catastrophe by just doing the simple test of blood sugar, rather universal screening for hyperglycemia in pregnancy. That is what the message is. And of course, the take-home message from our panel is, of course, that every obstetric unit and every person of the team must be trained and skilled to manage the obstetric collapse. There is no time for immediate referral, and referral in this unstable, unsettled condition may worsen the situation due to multiple issues. The team should manage this patient effectively then and there only. Of course, you have to call for help and have the help of multidisciplinary team. But just having the SDU and multidisciplinary team is not sufficient. Having the SDU alone is not sufficient. You have to have a multidisciplinary team. And of course, once again, the obstetric unit, every member should be well trained for managing the collapse. That is what is the message. And I just take this opportunity to thank all of you. All the panelists have, done wonders. The discussion was very good. And I would just take this opportunity to make a humble appeal for myself that I'm contesting for Foxy Vice President from West Zone. And I request your wholehearted support. There are 2 posts for West Zone. If I just introduce myself, I'm a practicing obstetrician since last 33 years now. Though initially I was into Government Medical College. My entire education is from BJ Medical College, Pune, UG and PG. And I'm here at a small district place, Yavatmal, with my 25-bedded own nursing home. So I request all of you, though I continued with my passion of academics, I have over 400 talks and more than 150 panels moderated till now, and 35+ national publications. So I request all of you to please vote for me and support me as your representative. So if any comment from the expert, we are very happy to have. Dr. Purandare, please go ahead. And of course, Karambalkar sir, if you can.
Yes, this was a nice discussion, giving many new points, and especially emergencies, small town like Chalisgaon. It is very important to know all these things. And thank you very much for having this. And we are there with you, no doubt. As a Vice President, you will do an excellent job. We are very sure. So we are friends for long many years. I know you personally. So definitely we give you all the best for the coming election.
Thank you, sir. Thank you so much. Thank you.
Best wishes, madam.
Thank you. Thank you, Dr. Vishal. Thank you so much. And
just like the panel discussion, last year we had near missed victory. So this year there will not be missed victory.
Yes, definitely. Thank you so much. Thank you.
Thank you. Thank you very much.
Thank you so much, ma'am, and wish you all the best for the upcoming elections.
Yes.
Thank you.
All
It
the
was an
best.
informative session.
Thank you.
Yes.
I thank the experts and of course all of you for sparing your valuable time and of course your inputs. Thank you so much. Thank you.
Thank you. Thank you.
Thank you. Thank you, madam.